Hi everyone. I hope all of you can see and listen to me. If my voice is audible to you people, please show me a thumbs up or some sign so that I come to know that you can hear me clearly. In the chat box, quickly, if you can put a thumbs up so that I'll come to know whether you can hear me clearly. Hi everyone. I hope all of you can. Right, so if you can listen to me and I'm audible clearly, please put a thumbs up there. Okay, right. So, this is Dr. Sakshi Arora Hans, and as you all know, today I'm going to discuss with you the recall questions of OBGY for of FMGE exam, which was held in December 2021. Now, the exam results are also declared, and still I am taking this recall session because, see, it's not only that particular question which is important. Whenever a question is asked, it's that topic which becomes very important for you. So not only these questions which I'll be discussing with you, which I'm sure you know what questions were there and what were the correct answers by now. But these topics become very important not only for the upcoming FMGE June 2022 session, but also for all the students who are preparing for NEET, because NBE is setting the paper and NBE is same setting papers for both FMGE and for NEET. So even though the same question might not be asked, but the questions may be from the same topic. So all these topics become very important for you. And I am going to discuss with you in detail about those topics, all the potential questions which could be asked from that particular topic from where the question was picked up. So yes, this session is going to be a little lengthy. Now, in total, there were 32 questions which were asked in OBGY. And if you ask me, the questions were simple questions. They were questions from the same topics which we always tell in the class that these topics are important. A few questions were tricky, and that is how the trend is these days. When I started teaching to FMG students, that was around 15 years back. The questions were very straightforward, direct questions. But gradually, the questions which are being asked to you people are becoming more conceptual, more clinical based, and more integrated. Satvik Raj, you've written Om Sai Ram. Yes, Om Sai Ram to all of you. And Happy New Year to all of you. May this new year bring a lot of happiness to you all, and may you all remain healthy, and may all your dreams come true in 2022. Keep safe, bacho, during this year. Again, there has been a surge in COVID-19 cases, so please keep safe. Wear your mask and maintain proper social distancing. Right, so coming to the first question, which was from one of the very expected topics, and that was about the MTP amendment. Now, on MTP, there were three questions which were asked in FMGE, right? So, obviously, abortions and MTP, that becomes a very, very important topic for your upcoming June 2022 session. First question on it related to MTP was, according to MTP Act 2021 guideline, MTP can be done up till how many weeks? Now, all of you know that MTP Act was passed in 1971 and the amendment bill was passed in 2021. Now, there are a few things which are unchanged, whether we talk about the original MTP Act or whether, I know all of you know the answer, that is 24 weeks, but I'm telling you a little bit more details over here. So there were few features which are same whether it was the MTP Act of 1971 or the amendment, and the things which are same are: number one, the criteria for who can do an MTP. There are three important criteria for who can do an MTP. So quickly write in the chat box the criteria for who can do MTP, which is unchanged. Number one, this is again a very, very important thing. So a person who's got a degree or a diploma or DNB in OBS and Gyne. Number one, they are eligible to perform MTP, right? Number two, If you are a registered medical practitioner, in other words, an MBBS pass out, then in that case, you can perform MTP if you have assisted in 25 MTPs. And out of those 25 MTPs, 5 MTPs you were the primary surgeon. You were the primary surgeon, then you are eligible to perform the MTP, right? Number 3, if you are a registered medical practitioner, in other words, an MBBS student, an MBBS pass out, and if you have done a 6 months house job in OBS and Gyne, then you are automatically classified to do and qualified to do an MTP. Right? Now, consent for MTP. Who is going to give the consent for MTP? Only females' consent is needed. Right? Again, this is not changed. This was same in the original MTP bill also and in the Amendment Act also. So, females' consent is needed. Male partners' consent is not needed. If female is less than 18 years or if she is mentally not stable, right? So, if she is mentally unstable, then the consent has to be given by a local guardian. So, these are the points which remain same, whether it was the original 1971 MTP Act or whether it was the amendment, right? Now, what are the things which have changed? Now, if a simple question comes to you like it came this year, that MTP can be done as per the amendment bill. So, as per the amendment bill, MTP can now be done up till 24 weeks. Whereas originally, as per the MTP Act, it could be done up till 20 weeks, right? Similarly, if they ask you if MTP is a result of rape or incest, then till how many weeks can it be done as per the MTP Amendment Act? Again, it can be done up till 24 weeks as per the amendment bill, right? And originally, it could be done up till 20 weeks. But if MTP is a result of contraception failure, then not only as per the original MTP Act, but as per the amendment bill also, till now also MTP can be performed only up till 20 weeks. So please remember that broadly we say that as per the MTP amendment bill, MTP can now be done up till 24 weeks, but there is an exception to that rule. And that exception is only if a female the result of the pregnancy is as a result of contraceptive failure, then you cannot do MTP up till 24 weeks now also. Now also you can do MTP only up till 20 weeks if MTP is a result of contraceptive failure. If MTP is a result of rape or incest, then you can do it up till 24 weeks. Now, as far as the congenital anomalies of the fetus are concerned, MTP for a severely malformed fetus, originally you can do it up till 20 weeks, but now there is no upper gestational age limit. No upper gestational age limit. But then, this has to be approved by a board. This has to be approved by a medical board. Only if the medical board says that yes, the fetus is severely malformed and such malformations are incompatible with life, then MTP now can be done up at any upper limit of gestational age. Now, who are the members of the medical board? So, please remember, members of the medical board are 4 members. Number 1, a gynecologist. Number 2, a pediatrician. Number 3, a radiologist. And number 4, a person who's assigned by the state. Right? So, if you cannot read what I have written, number 1 is a gynecologist. Number 2, a pediatrician. Number 3, a radiologist. And number 4, state. So, a person who's assigned by the state. Clear to all of you? So if this medical board says that yes, the fetus is congenitally malformed and such malformations are incompatible with life, so now MTP can be done at any gestational age, right? Okay. Then the other changes which have come are single doctor's opinion was needed for performing MTP up till 12 weeks as per the original MTP Act, but as per the MTP Amendment Bill, it is up till 20 weeks. Up till 20 weeks if MTP is being performed, then only single doctor's opinion is needed. Earlier, it was said that if MTP was being performed between 12 weeks to 20 weeks, two doctors' opinion was needed. Now they say that if MTP is done between 20 to 24 weeks, then two doctors' opinion is needed. Right? I hope all of you are understanding. I am not going to remove this. Don't worry. This is going to remain on my channel. But I want you to be a little more interactive and I want all of you to copy all these points because all these points are important for your upcoming exams, right? So this was the first question which they had asked on abortions and MTP. Now the second question which was asked on abortions and MTP was, a G3P2 lady presents with 8 weeks pregnancy for MTP. What number of the instrument shown in figure should be used? Now all of you know that this over here is a plastic cannula. And this plastic cannula has a triangular opening, two triangular openings, a plastic cannula, and this is what is a Carman's cannula. A Carman's cannula, right? So when you are doing MTP at 8 weeks, right, you go for suction evacuation, and Carman's cannula is an instrument which helps in suction evacuation. Please remember that up till 7 weeks of pregnancy, the best method for doing MTP is medical abortion. Between 7 to 12 weeks, it is suction evacuation, which is done using a Carman's cannula. And if you are doing in rural areas where suction evacuation cannot be done, then you are going to go for MVA. What is MVA? Menstrual vacuum aspiration, right? So then you are going to go for menstrual vacuum aspiration. Clear? Manual vacuum aspiration, sorry, manual vacuum aspiration, that is MVA. Manual, not menstrual, manual vacuum aspiration. Right, that is an alternative to do suction evacuation in areas where electricity is not available, where suction evacuation cannot be done. Now in second trimester, also the best method is medical abortion using prostaglandins, that is misoprost. Now the difference between medical abortion which you are doing in first trimester and the medical abortion which you do in second trimester is that in first trimester when you are doing medical abortion, it's an OPD procedure. Whereas when you are doing medical abortion in second trimester, it's an IPD procedure. You have to admit the patient and then you have to give misoprost because patient is going to experience a mini labor kind of a thing, right? The other thing which I want you to note over here is that up till 12 weeks, I have two methods of doing abortion. Up till 7 weeks, medical abortion is the best. Between 7 to 12 weeks, suction evacuation. In other words, your surgical abortion is the best method. But in second trimester, we do only medical abortion, right? Rarely we go for, that means medical abortion using misoprost. Rarely we go for surgical abortions like dilatation and curettage, that we do rarely, right? The best method for second trimester abortion is medical abortion using misoprost, in which you have to admit the patient, right? Now coming to details about suction evacuation. So as I told you, suction evacuation, it is the best method for doing MTP between 7 to 12 weeks, and you are going to do it with the help of a Carman's cannula. This Carman's cannula is going to be attached So over here, this is a Carman's cannula, and this Carman's cannula will be attached to a suction machine, and with the help of this, you are going to do suction evacuation. Now, the number on the Carman cannula, it corresponds to the diameter of the cannula in millimeters, right? So if there is a 6 number Carman cannula, that means it is 6 millimeters in diameter. And I've also told you this in lectures that the size of the cannula will be equal to the duration of pregnancy in weeks, right? So you are going to pick up that number of cannula which is equal to the duration of pregnancy in weeks. So over here in the question, you have 8 weeks pregnant female. So obviously I'm going to pick up 8 number Carman's cannula, right? Clear to all of you? Yes. Now, other important points for suction evacuation are that what is the pressure generated during suction evacuation? It is 600 millimeters of mercury. That's very, very important. Now, as I told you, an alternative for suction evacuation is manual vacuum aspiration. And manual vacuum aspiration is done with the help of a syringe. So, I'll just show you a syringe. This over here is a manual vacuum aspiration syringe. Now again, this is a very, very important visual. Please remember, it's a very, very important visual. Now in this manual vacuum aspiration syringe, how are you going to identify the syringe? You are seeing 2 pinch valves. Can you see these 2 pinch valves? So if you get a syringe with 2 pinch valves, that is a manual vacuum aspiration syringe. And for manual vacuum aspiration, please remember the capacity of the syringe is 60 ml. This is a 60 ml syringe. It is not 50 ml. Right? That's an outdated answer. 60 ml is the volume of the syringe. Then if they ask you what is the pressure generated during manual vacuum aspiration, best answer is 660 millimeters of mercury, right? If 660 millimeters of mercury is not given in the options, then you are going to choose the answer as 600 millimeters of mercury. Clear to all of you? Best is 660 millimeters of mercury, right? Now, there is another syringe which is a menstrual regulation syringe. Now, how are you going to differentiate between menstrual regulation syringe and manual vacuum aspiration syringe? Menstrual regulation syringe has a single valve, right? And menstrual regulation syringe is used for doing abortion up till 6 weeks of pregnancy. Manual vacuum aspiration is a syringe which is you are going to do it for between 7 to 12 weeks. It has got 2 pinch valves and it is going to be used between 7 to 12 weeks, right? Over here you have a single valve and you are going to use it only up till 6 weeks. Very, very important information, right? Then, now when you are doing suction evacuation with the help of Carman's cannula, you have to introduce the Carman's cannula into the internal os, right? And normally the internal os is closed like this. So I will have to first dilate the internal os, then only I will be able to introduce Carman's cannula. So in order to dilate the internal os, the instrument which you are going to use will be a Haggard's dilator. Right, so this is a Haggard's dilator which is going to be used to dilate the internal os, right? So when you are doing suction evacuation, first thing what you are going to do is you are going to dilate the internal os using Haggard's dilators, and then you are going to take the Carman's cannula inside. Now while you are dilating the internal os using Haggard's dilator, what can happen? Suddenly the dilator can slip from your hand and that can lead to perforation, right? Or what could be that when you are doing suction evacuation with the help of Carman's cannula, all of you know that the pregnant uterus is very, very soft. So when you are doing suction evacuation, it could be that there can be a perforation with the help of Carman's cannula. So if perforation is happening at the time of suction evacuation, depending upon which instrument led to perforation, the further course of action depends on that. So if perforation is happening with Haggard's dilator, Please remember, then there is nothing to worry. You just have to stop the procedure, and you have to monitor the patient. That's all what you have to do. Monitor the patient's vitals, right? But if perforation is happening with Carman's cannula, now in this case, what you're going to do? You are going to stop the procedure. You are going to let Carman's cannula be inside. You are not going to take out Carman's cannula, because you don't know that this Carman's cannula may bring a part of intestine or mesentery along with it. Right? So please do not take out Carman's cannula, and immediately take the patient for laparotomy. Immediate laparotomy. Right? So this is the management of perforation when perforation happens with Carman's cannula. If it is happening with Hagar's dilator, just monitoring the patient and nothing else. Right? Manual vacuum aspiration syringe, I told you the capacity of the syringe is 60 ml. Pressure, best answer is 660 mm of mercury. Second best answer is 600 mm of mercury. Right? Then, what are the signs of complete evacuation? So, number one sign of complete evacuation is that the size of the uterus will decrease. Number two, when the evacuation process is complete, when the product of conception will come out, तो जो internal os है वो close होने लगेगा. Right? So, when internal os will start closing, it will grip the Carman's cannula. Right? So you will get a gripping sensation at the level of internal os. Then you are going to get a grating sensation in the endometrium, and you are going to get appearance of fresh blood. Jitna clotted blood tha, dark colored blood tha, jitna product of conception tha, all of that would come out, or now fresh blood will start coming out. वो सारा पहले बाहर निकलेगा, and now fresh blood will start coming out. So you will come to know that okay, the process of suction evacuation is complete. Please remember that you should know what is the end point of suction evacuation. Why? Because if you do excessive curettage, अगर हमने excessive curettage कर दिया, बहुत ज़्यादा evacuation कर दिया, बहुत ज़्यादा curettage कर दिया, what happens? Later on, it will lead to Asherman syndrome. What is Asherman syndrome? Asherman syndrome is intrauterine adhesions, which happens because you have done excessive uterine curettage. Clear to all of you? Yes? Okay. So this is all the important points which I wanted you to know on question number 2, which was on Carman's cannula. Right? So answer we've already done. Coming to this instrument. Now, what is this instrument and where is it used? As I told you, surgical abortion is rarely done in second trimester. But if surgical abortion is done in second trimester, then you do it with the help of ovum forceps. Ovum forceps को identify करने के लिए you need to know two things. Number one, इसका जो proximal end होता है, that is spoon shaped end, right? So it has a spoon shaped end. And number two, although this is a forceps, this is not a scissors. देखो बच्चों, जितने भी instruments होते हैं ना, उसमें forceps and scissors में एक important difference होता है. Forceps always comes with a lock, whereas scissors don't have a lock. But there are two forceps which we use in OBGY in which there are no locks. So normally forceps will have a lock, right? And scissors will not have a lock. But there are two forceps which don't have lock. Number one is ovum forceps. As you can see, इसके distal end पे there is no lock. Normally, otherwise, इस तरीके से एक lock present होता, but here it is not present, right? And number two is a Chitel forceps. with which you pick up the sponge and the instruments, right? Not the sponge, but the instruments rather, basically. So that is a chittle forceps. So from the instrument tray, when you are picking up the instruments, then you use a Chittel's forceps. So Chittel forceps and ovum forceps, they don't have a lock. Now, for all details about instruments and obs and gynae, because this time a few images were asked related to instruments and obs and gynae, there is a video on YouTube on Marrow Live channel which I have recorded on instruments and obs and gynae by Dr. Sakshi Arora on Marrow Live on YouTube. I want all of you to watch that video very carefully and take down all the important points from there. Right, because in NEET also there was a question on instruments which are used in cesarean section, and now in FMGE also there were two questions. One was on this Carman's cannula, then there was a question, three questions rather, on curate and a uterine sound. So there were many questions which were asked on instruments. So that is a very, very important video which I want all of you to watch, right? Coming to third question which was asked on abortions. So this is: a lady presents with 45 days of amenorrhea. She wants abortion. If you are a treating doctor, what would you prefer? As I told you, up till 7 weeks, that means up till 49 days, I would prefer medical abortion. And medical abortion, this which I am going to do in the first trimester, I am going to do it on an OPD basis, right? So I am going to do it on OPD basis. Now, in India, medical abortion can be done up till 7 weeks, right? But as per WHO, medical abortion can be done up till 9 weeks. So, in India, we can do it up till 7 weeks, that is 49 days. But as per WHO, you can do it up till 63 days. And as I told you, it will be an OPD procedure. Now, up till 7 weeks, the regime which we use is, on day 1, I am going to give tablet mifepristone to the patient, and I'm going to give one tablet which will be 200 mg tablet, which I'm going to give orally to the patient, right? And then after between 24 to 48 hours. Now over here again there is a change. Earlier it was said that mifepristone देने के बाद 48 hours wait करना ही करना है and तब misoprost देना है. So day 1 पे we used to give mifepristone and day 3 we used to give misoprost. Now the recommendation is that once you've given mifepristone, between 24 to 48 hours you can give misoprost. Have you understood this change? Earlier it was कि 48 hours के बाद ही देना है. Now they say between 24 to 48 hours you can give misoprost, and up till 7 weeks, how much misoprost are you going to give? 400 micrograms, and that is a very, very common mistake which you all do. So how much misoprost are we going to give? 400 micrograms of misoprost, which can be given orally, which can be given sublingually, which can be given vaginally, or which can be given buccally by any route. So day 1 पे single tablet देंगे mifepristone 200 mg, and after 24 to 48 hours we are going to give 400 micrograms of misoprost. Now when you give misoprost, within 4 to 6 hours of giving misoprost, patient will start passing the product of conception. So उसके 4 to 6 hours के बाद ही product of conception will start passing out, and you are going to tell this female to follow up after 2 weeks. Now, one very important thing which I want to tell you, that when a patient comes to you for medical abortion, there is no need for doing an ultrasound. So you are not going to rule out ectopic pregnancy in all patients in whom you are giving medical abortion, right? Only if the patient comes to you with pain in abdomen and you are suspecting ectopic pregnancy, then only you have to do an ultrasound. So ultrasound is not mandatory before you do a medical abortion. Similarly, when you are calling up the patient after 2 weeks for follow-up to see कि सारा product of conception बाहर निकला कि नहीं निकला, now again you are going to use your clinical judgment here. It is not necessary कि after 2 weeks हम ultrasound करा कर देखें कि सारा product of conception बाहर आ गया कि नहीं आ गया. Clinical judgment use karoge. If you feel the uterus has involuted, uterus has come back to its size, if the spotting has, there is no spotting, no bleeding to the patient, so that means the entire product of conception has come out, and that means there is no need to get an ultrasound done, right? So for medical abortion, there is no need for ultrasound before abortion and after abortion. Only if you feel it is relevant in that particular patient, then you will get it done. Is that clear to all of you? Yes. Now, this was the protocol which has to be followed up till 7 weeks. Now, if patient is coming to you between 7 to 9 weeks for medical abortion, now, as per WHO, between 7 to 9 weeks also we can go for medical abortion. And now between 7 to 9 weeks, it is up to us. Between 7 to 9 weeks, I may go for OPD procedure or I may admit the patient. That is up to me. Normally, we prefer it as an OPD procedure, but between 7 to 9 weeks, I can go for inpatient also. I may admit the patient and give her medical abortion also, right? Now, again, what is the method? The method is the same, that on day 1, I am going to give her mifepristone 200 mg orally. And then between 24 to 48, after 24 to 48 hours of giving mifepristone, I am going to give mesoprost. Now, the dose of mesoprost which I am going to give will be 800 micrograms, which I am going to give sublingually, vaginally or buccally. I am not going to give orally, right? So, first trimester abortions may up till 7 weeks, it is definitely an OPD procedure. Between 7 to 9 weeks, it's your choice. And second trimester में जब आप medical abortion कर रहे हो, definitely it is an IPD procedure. You have to admit the patient. Clear to all of you? Everything about medical abortion, is it clear? So quickly in the chat box, if you can write that it's clear. Okay. Now, next question was a very, very straightforward question, which was maximum amount of amniotic fluid seen at. And if you remember, and if you are a subscriber of Marrow, you remember that I have shown you exact wordings of Williams, which says that maximum amount of amniotic fluid is seen at 34 weeks, right? That is the best answer. Right, and the second best answer is the range, and the range is 32 to 34 weeks. Now, thankfully over here, you have got only 32 weeks. So, you are going to mark it as 32 weeks. अब अगर 32 and 34 दोनों होता, then you would have marked 34 weeks as the answer. So, answer over here is 32 weeks. Now, sometimes you do get theoretical questions, and for theoretical, straightforward, direct questions, which you get in NEET as well, I want all of you to quickly take a screenshot of this, where I have told you the, at what gestational age, what amount of fluid is seen. Right? So, the amount of fluid between 32 to 34 weeks is 1 liters. Then at 36 weeks, it is 900 ml. At term, 800 ml. At 42 weeks, 200 ml. At 12 weeks, 50 ml. At 20 weeks, 400 ml. And 24 weeks, 500 ml. So, this is nothing which I have to explain over here. This is purely theoretical. And all of you remember the color of amniotic fluid, the abnormal color of amniotic fluid, the composition, specific gravity. This is something which we tend to forget. So this is something which you have to remember. Write it down in your 20th notebook or in your last minute revision notebook, so that these theoretical values you do not forget. Right? Coming to this question. Identify this ultrasound of the uterus. Again, a very, very straightforward question, where you know typically that this ultrasound is an ultrasound which is showing you a snowstorm appearance, right? And all of you know by heart that a snowstorm appearance is seen in case of molar pregnancy, especially in case of complete mole, right? So, a few important points related to this. Let us quickly do that. So, snowstorm appearance on ultrasound. Now, please remember that sometimes in your questions, to make it a little more difficult, appearing difficult, they may, instead of saying snowstorm appearance, they may use the term honeycomb appearance. So whether they say honeycomb appearance on ultrasound or whether they say snowstorm appearance on ultrasound, it's one and the same thing. And it is seen in case of complete mole. The other name for complete mole is a vesicular mole or a high datiform mole. All of them mean the same thing, right? A complete mole is more common in comparison to partial mole. One important point. Number two, complete mole is diploid. That means what is the karyotype? Karyotype, most common karyotype is 46XX. That's very, very important. The most common karyotype of complete mole. Now, how is a complete mole formed? A complete mole is formed when an empty ova is fertilized by a single sperm, and then the chromosome number of the single sperm duplicates. So whatever chromosomes this complete mole has, whatever genetic material this complete mole has, that belongs entirely to the father, right? So a complete mole is monospermic. Whereas when we talk about partial mole, the partial moles are triploid. Their chromosome number is 69XXY. And how is a partial mole formed? A partial mole is formed when an ova, it is not an empty ova, when an ova is fertilized by two sperms. So in case of partial mole, extra genetic material belongs to the father. It has maternal genetic material also, but extra material from the father as well. Now when you look at an ultrasound in partial mole, you do not get a snowstorm appearance. Why? क्योंकि partial mole में हमें parts of fetus मिलते हैं, right? Complete mole में snowstorm appearance इसलिए मिलता है because in complete mole there is no fetal part. Whereas partial mole में some fetal part will always be present. अब अगर imagine करो कि एक अल्ट्रासाउंड में थोड़ा सा fetus का part दिख रहा है, पूरा fetus नहीं दिख रहा है, तो सबसे पहले हमारा शक किस पे जाएगा? First of all, I am going to think about an incomplete abortion or a missed abortion, and then I am going to think about partial mole, right? So the differential diagnosis which is going to come to me in my mind when I see a part of the fetus and patient coming to me with bleeding. Patient दोनों में, molar pregnancy में patient comes to you with first trimester bleeding, abortion में भी patient comes to you with first trimester bleeding. A partial mole में bleeding है and part of the fetal tissue is being seen. So what am I going to think? I'm going to think that this is a case of incomplete abortion rather than thinking that this is a case of partial mole. So on ultrasound, you are going to get appearance of incomplete abortion. So partial moles are very oftenly confused with incomplete abortions, right? Okay, now continuing with this, what is the management of molar pregnancy? Simple question पूछा जाए, management of molar pregnancy, your answer will be suction evacuation. Suction evacuation. Now suppose if they ask you management of theca lutein cyst in molar pregnancy. Now management of theca lutein cyst in molar pregnancy पूछेंगे, तो theca lutein cyst, they do not need any management. No specific management for theca lutein cyst. जब आप suction evacuation करोगे molar pregnancy का, तो automatically ये cyst भी regress हो जाएंगी. So either in your options no management will be written or suction evacuation will be written. Why suction evacuation will be written? Because this suction evacuation means suction evacuation of molar pregnancy. कि molar pregnancy का suction evacuation कर दो and the cyst will automatically regress. Right? Now, if your question says that there is a female who is more than 40 years, right? Plus she has a complete mole, plus her family is complete. What is the management? Now, in this case, अगर ये specific question ऐसा पूछा जाए That female is more than 40 years. It's a case of complete mole and family is complete. What is the management? Now management becomes hysterectomy. Right? So now you are not going to say suction evacuation. Now you are going to say hysterectomy. Very good. I can see so many of you giving me correct answers. Now, this was a snowstorm appearance which you were getting on ultrasound. If you get a snowstorm appearance on chest X-ray, what does that mean? That means it is a choriocarcinoma which has metastasized to the lungs. Right? But please remember, most common appearance of choriocarcinoma which has metastasized to the lungs on chest X-ray is not snowstorm appearance. It is cannonball appearance. Cannonball appearance. That is the most common appearance. Second most common appearance is snowstorm appearance. Next important point is, as far as FMG exams are concerned, even for PG entrance, you don't need to know the complete FIGO staging of choriocarcinoma. In FIGO staging of choriocarcinoma, you just have to know stage 3. So whenever there is lung metastasis means stage 3. So please remember, lung metastasis occurs in stage 3 of choriocarcinoma and lungs are the most common site for metastasis, followed by vagina. Right? Second most common site is vagina, in which choriocarcinoma occurs in the form of suburethral nodule. Suburethral nodule. Clear to all of you? Okay. Choriocarcinoma is chemosensitive. Right? Similarly, if you have an invasive mole, it is chemosensitive. But PSTT, that is placental site trophoblastic tumor, and ETT, epithelioid trophoblastic tumors, these are chemo-resistant, and in this case, the management is hysterectomy. Right? For choriocarcinoma and invasive mole, management is chemotherapy. So their management is chemotherapy. But for PSTT, placental site trophoblastic tumor, and epithelioid trophoblastic tumor, management is hysterectomy. Just last question before I leave this question. So, what biochemical marker are you going to use for following up a molar pregnancy? So once you have done suction evacuation of an H mole, how are you going to follow up the patient? You are going to follow up the patient by using beta HCG levels, and you are going to follow up for 6 months. Right, so weekly I'm going to do beta HCG levels till the beta HCG levels become normal, and then I'm going to do it monthly for 6 months. Now during this 6 months, you are going to advise the patient not to become pregnant, right? So what is the contraception of choice which you are going to advise to the patient? The contraception of choice will be oral combined pills, right? And just one more thing, which is the most common gestational trophoblastic neoplasia after H mole evacuation? So after H mole evacuation, what is the most common gestational trophoblastic neoplasia? Anyone? Quickly write in the chat box. Most common gestational trophoblastic neoplasia after evacuation of H mole. I am waiting for some time so that I can see your answers. I can see you writing beta HCG and everything, but now write the answer to the question which I have asked you. Most common gestational trophoblastic neoplasia after evacuation of H mole. I can see a few answers coming up. Only 3 of you have given me the answers. Yes, I have got confirmed correct answer from only one, and that is Adi. Adi has written it very correctly and very quickly that the most common is invasive mole. That's a very common mistake which you people do. You say that the most common is choriocarcinoma. No, most common is not choriocarcinoma. Most common gestational trophoblastic neoplasia after evacuation of H mole is invasive mole. Clear to all of you? Do not say it's choriocarcinoma. These are two different questions and two different answers. So one question is, since you didn't give me the correct answer, that is why I'm just telling you two very important questions here. Question 1 is most common GTN after evacuation of H mole. Your answer will be invasive mole. None of you are going to say it as choriocarcinoma, right? Question number 2. Choriocarcinoma most commonly occurs after. Now, if this is the question that choriocarcinoma most commonly occurs after, then your answer is H mole evacuation. Right? So these are two different questions with two different answers, and both these questions and their answers you have to remember. Okay? Now coming to question number 6. Which of the following is an indication after full term pregnancy, doctor and caffeine? If they ask you this question, most common GTN after full term pregnancy, your answer will be choriocarcinoma. But if they ask you PSTT most commonly occurs after, then your answer will be full term pregnancy. So please remember these 4 important one-liners. Very, very important. Right? Okay. We are going a little slow, but that's okay. If your doubts are getting cleared, if your concepts are getting cleared, I'm okay with that. So which of the following is an indication for surgical management of ectopic pregnancy? So all of you know, yes, this will be available after the session also, the YouTube session. This will stay on my channel. So come to question number 6 quickly. Which of the following is an indication for surgical management of ectopic pregnancy? Now please remember that ectopic pregnancy patient, they can come to you as a case of ruptured ectopic or as unruptured ectopic. Now, in case of ruptured ectopic, there is only one management. And what is the management? Management is surgery. What surgery are you going to do? You are going to open her abdomen, laparotomy, by laparotomy, right? So, open the abdomen by laparotomy plus do a salpingectomy. What is a salpingectomy? Salpingectomy is you have to remove the tube which has been ruptured. Now, this has to be done whether family is complete or not complete. So, whether the patient's family is complete or not complete. If it is a case of ruptured ectopic, there is only one surgery, and that surgery is salpingectomy, right? But if it is a case of unruptured ectopic, in unruptured ectopic, the best management always is medical management. That's the best management, right? Now, when we talk about medical management, there are certain absolute requirements for medical management. So these criteria should definitely be fulfilled, and there are certain relative criteria for medical management. The absolute criteria is that it should be a case of unruptured ectopic. In other words, on ultrasound, free fluid should be less than 100 cc, right? And the relative requirements are HCG levels should be less than 5,000 international units, size of the ectopic should be less than 4 centimeters, cardiac activity should be absent, and there should be absent or minimal pain, which means that if HCG levels are less than 5,000, I'm going to prefer medical management. If cardiac activity is absent, I'm going to prefer medical management. But suppose if cardiac activity is present, then what? So if cardiac activity is present, I may do medical management, but then medical management is not the best management if cardiac activity is present. The chances of failure of medical management will be a lot if cardiac activity is present, and that is why if cardiac activity is present, then the preferred management is surgical management, right? Now suppose if you are doing medical management when cardiac activity is present, although that is not the preferred method, then please remember that the size of the ectopic should be less than 3.5 centimeters and not 4 centimeters. So are you understanding कि मेडिकल मैनेजमेंट हमेशा हमेशा अनरप्चर्ड एक्टॉपिक में करते हैं. मेडिकल मैनेजमेंट के लिए द क्राइटेरिया, द रिलेटिव क्राइटेरिया इज दैट बीटा एचसीजी शुड बी लेस देन 5000. Then your cardiac activity should be absent or minimal pain hona chahiye, and size should be less than 4 centimeters. So suppose size is more than 4 centimeters or cardiac activity is present, in that case I may do medical management, but the chances of failure are high, and that is why in all these cases I would be preferring surgical management, right? So suppose if they say that in unruptured ectopic pregnancy, what is the preferred management? Your answer will be preferred management is medical management. Simple question. Now, if they say unruptured ectopic, if they say about ruptured ectopic pregnancy, ki ruptured ectopic pregnancy mein what is the preferred management? Ruptured ectopic pregnancy mein preferred management is surgical management, and the preferred surgery is salpingectomy. Clear to all of you? Right? Now how they can ask you questions. Now, okay, just one more thing. As I am telling you that in unruptured ectopic pregnancy, best is medical, but the other options which you have are expectant management and surgical management. Now, what is the surgical management in unruptured ectopic pregnancy? Unruptured ectopic pregnancy में कौन सी surgery करेंगे? So I am just going to clear this from here and right. So unruptured ectopic में the surgery which you have to do, you are going to do a laparoscopic surgery. So you're going to open the abdomen by laparoscopy, and if family is complete, you are going to do salpingectomy. If family is not complete, you are going to do salpingostomy. Salpingostomy. So what do you do in salpingostomy? If this is the tube जहाँ पे ectopic है, I am going to give an incision on the antemesenteric border, and I'm going to take out the ectopic pregnancy by hydrodissection, and then I'm going to leave the tube like this. I am not going to put any sutures. This is what is called as salpingostomy. इसी को linear salpingostomy भी कहते हैं. Linear salpingostomy भी कहते हैं. Please remember the surgery which is never done in ectopic pregnancy, that is salpingo-oophorectomy. You never remove the ovaries in ectopic pregnancy unless and until it is an ovarian ectopic. अगर ovarian ectopic है, that is a different case altogether, तब ovaries remove करनी पड़ेंगी. But otherwise in ectopic pregnancy you remove only the tube and you do not remove the ovaries, right? Okay. Now suppose your question says there is an ectopic pregnancy in a female with decreasing values of HCG, and your question says that the HCG is less than 1000 international units and simultaneously HCG decrease कर रहा है. अगर question ऐसा आ रहा है कि HCG is less than 1000 and the levels of HCG are decreasing on its own, then the management is expectant management. So expectant management का criteria यही होता है कि it has to be unruptured ectopic, HCG levels should be less than 1000 and they should be decreasing. Please remember, अगर question में आपको उन्होंने expectant management tick करवाना है, तो वो दो वैल्यूज देंगे एचसीजी की, एक वैल्यू ज्यादा देंगे, एक वैल्यू ऑटोमेटिकली कहेंगे कि नेक्स्ट डे ऑटोमेटिकली द लेवल्स ऑफ एचसीजी हैड डिक्रीज्ड, देन ओनली यू आर गोइंग टू से आई एम गोइंग टू डू एक्सपेक्टेंट मैनेजमेंट. अदरवाइज अनरप्चर्ड एक्टॉपिक में योर आंसर शुड ऑलवेज बी मेडिकल मैनेजमेंट अनलेस एंड अनटिल कार्डियक एक्टिविटी प्रेजेंट है या एचसीजी वैल्यूज मोर देन 5000 है, तब इट becomes surgical management. For example, if your question says there is an ectopic pregnancy in a female with absent cardiac activity, her HCG levels are 3000 international units, size is 3 centimeters. अब क्वेश्चन कह रहा है कार्डियक एक्टिविटी एब्सेंट है, राइट, HCG 3000 है यानी कि लेस देन 5000 हो गया, साइज इज 3 सेंटीमीटर्स दैट इज लेस देन 4 centimeters हो गया. So what is going in my mind? In my mind I am thinking कि I am going to mark the answer as medical management. अब अगर आप क्वेश्चन को केयरफुली एंड तक नहीं पढ़ोगे तो आप आंसर टिक कर दोगे एज मेडिकल मैनेजमेंट. बट प्लीज रीड द क्वेश्चन फर्दर. व्हाट इज द क्वेश्चन सेइंग? क्वेश्चन इज सेइंग पेशेंट्स फैमिली इज कंप्लीट. The moment they say patient's family is complete, your answer changes from medical management to surgical management. So now your answer becomes surgical management. Is that clear to all of you? So please read your questions very, very carefully and please do not be in a hurry to tick mark the answer. Read your question till the end. Read all the options very carefully before you tick the answer. Right? Now suppose they say management of heterotopic pregnancy. What is a heterotopic pregnancy? A heterotopic pregnancy is a twin pregnancy in which one fetus is intrauterine and second fetus is ectopic. तो ऑब्वियसली अगर एक इंट्रायूट्राइन है एंड एक एक्टोपिक है तो आई कैन नॉट डू अ मेडिकल मैनेजमेंट, बिकॉज अगर मैंने मेथोट्रेक्सेट दिया तो इंट्रायूट्राइन फीटस की भी डेथ हो जाएगी, राइट. सो इन हेट्रोटॉपिक प्रेगनेंसी माय आंसर बिकम्स surgical management because I'm going to remove only the ectopic pregnancy. Intrauterine pregnancy can be continued if the patient desires. Clear to all of you? Yes. Now, one very important question which they confused in NEET. See, in ectopic pregnancy also we give methotrexate for medical management, and in molar pregnancy also we use methotrexate. So methotrexate ectopic में भी यूज होता है and methotrexate molar pregnancy में भी यूज होता है. Now in ectopic when you use methotrexate you give a single dose regime, right. ये single dose हम देंगे day 1 पे, फिर day 4 पे हम चेक करेंगे बीटा HCG levels and day 7 पे हम चेक करेंगे बीटा HCG levels, right. लेकिन जब हम मोलर प्रेगनेंसी में मेथोट्रेक्सेट यूज कर रहे होते हैं वी गो फॉर अ मल्टी डोज रिजीम वेयर ऑन day 1, day 3, day 5, day 7 you are going to give methotrexate and you are going to alternate it with folinic acid, right. So in molar pregnancy methotrexate is a multi dose regime. In ectopic pregnancy methotrexate is a single dose regime. Clear to all of you? Yes? Okay. Cardiac output returns to normal after how many days of delivery? Now again there is a lot of controversy as far as this question is concerned. Now I'm going to tell you exactly what Williams says. Williams says, Williams Orbs 25th edition page 655. This says that by 10 days after delivery, cardiac output returns to normal, right. So clearly लिखा हुआ है that by 10 days cardiac output returns to normal. Blood volume returns to normal by 1 week after delivery and cardiac output returns to normal by 10 days after delivery. So definitely answer to this question is 10 days. Okay, question number 6 का हमने आंसर नहीं किया था. Which of the following is an indication for surgical management of ectopic pregnancy? Ectopic mass more than 4 centimeters. Yes, that is the answer. Serum beta HCG levels less than 1000. Serum beta HCG levels अगर less than 1000 है, it is expectant management. Patient wants to continue pregnancy, ऐसा कुछ होता नहीं है. Unruptured ectopic pregnancy में best management is medical management. So the answer over here is option A. If size of the ectopic is more than 4 centimeters, then you have to go for surgical management. Or if cardiac activity is present, or if beta HCG is more than 5000, or if it is ruptured ectopic, then you have to go for surgical management. Clear to all of you? Now we were talking about cardiac output, and I told you that Williams specifically says that cardiac output comes back to normal 7 days after delivery. So when does cardiac output become maximum? Cardiac output is maximum immediately after delivery, followed by second stage of labor, followed by late first stage of labor, that is the active phase of labor, and then between 28 to 32 weeks of pregnancy. So if your question is about maximum chances of heart failure, so maximum chances of heart failure are also immediately after delivery, then in the second stage of labor, then in active phase of labor, and then between 28 to 32 weeks of pregnancy. अगर केवल pregnancy की बात करी जाए कि pregnancy में cardiac output maximum कब होता है, तो then it is between 28 to 32 weeks. इन दोनों में से अगर एक मार्क करना हो, so it is 32 weeks. Right? Cardiac output will return to normal by 10 days and blood volume is going to return to normal by 1 week after delivery. Clear to all of you? Any confusions here? Okay. Coming to next question, absolute contraindication to breastfeeding. Now, absolute contraindications to breastfeeding, I want all of you to understand. एब्सोल्यूट कॉन्ट्राइंडिकेशंस वो कॉन्ट्राइंडिकेशंस हैं जो कि डेवलप्ड कंट्रीज एंड डेवलपिंग कंट्रीज दोनों में होते हैं, राइट? Whereas there are few contraindications which are present only for developed countries. Developing countries में वो नहीं है contraindications. Then they are not absolute contraindications. Absolute contraindications means contraindications both for developed and developing countries. And there are 5 contraindications which are absolute contraindications. 3 related to mother, 2 related to baby. Number 1, if mother is an IV drug abuser or she takes excessive alcohol. Number 2, if she is on anti-cancer drug. Number 3, if she has herpes simplex lesions on breast, right? And केवल herpes simplex होना is not a contraindication. Herpes simplex के lesions breast पे होना is a contraindication. Then, if baby has lactose intolerance or if baby has galactosemia. These are 5 contraindications which are absolute contraindications whether it is a developed country, whether it is a developing country. As far as infections are concerned, unless and until herpes simplex के lesions breast पे हो तब तक का that's not an absolute contraindication, right? So in general हम ये कह सकते हैं कि none of the infection is an absolute contraindication for breastfeeding. Right? Only if herpes simplex lesions are present on the breast, then it's an absolute contraindication. Now, what are those contraindications which are contraindications for developed countries but not a contraindication in developing countries? So, pulmonary tuberculosis, active or untreated pulmonary tuberculosis is a contraindication in developed countries but not in developing countries. Similarly, HIV positive mother. According to our national guidelines, HIV is not a contraindication to breastfeeding. So this is not absolute. Absolute केवल वो 5 थे. TB and HIV are not contraindications in developing countries. And please remember, कहीं पर भी contraindication नहीं है. Hepatitis C infection, hepatitis B infection, HPV, COVID-19, human papilloma virus and rest of the torch infections. ये कहीं पर भी contraindication नहीं है. Right, so COVID is not a contraindication for breastfeeding. Torch infections, HPV, hepatitis B, hepatitis C, they are not a contraindication anywhere. Clear to all of you? Yes, so this is again a very, very important table. So over here, absolute contraindication to breastfeeding. Cytomegalovirus, no. HPV, as I told you, ये कहीं का भी contraindication नहीं है. Hepatitis कहीं का भी contraindication नहीं है. Galactosemia, yes, it's an absolute contraindication. So answer over here is option C, and I'm sure all of you know the answer as well. Coming to question number 9, hormone responsible for pain during breastfeeding. Now, a few hormones which you have to remember for breast, which act on breast, and you have to remember. Number one, if they ask you which hormones are responsible for growth of the breast during pregnancy. For growth of breast during pregnancy, estrogen and progesterone both are needed. Estrogen is responsible for the growth of ducts, whereas progesterone is responsible for the growth of alveoli or SNI. Right? Now, so many times हम जब HRT देते हैं, हार्मोन रिप्लेसमेंट थेरेपी देते हैं, एंड हार्मोन रिप्लेसमेंट थेरेपी हम या तो ओनली ईस्ट्रोजन दे सकते हैं या ईस्ट्रोजन प्लस प्रोजेस्टेरोन दे सकते हैं. राइट? जब आप केवल ईस्ट्रोजन देते हो एंड फीमेल में यूट्रस प्रेजेंट है, तो इस ईस्ट्रोजन की वजह से एंडोमेट्रियल कैंसर हो सकता है. राइट? आपने जब प्रोजेस्टेरोन ऐड कर दिया तो चांसेस ऑफ एंडोमेट्रियल कैंसर गो डाउन. बट द प्रॉब्लम इज कि जब आप प्रोजेस्टेरोन ऐड करते हो, then there are increased chances for breast cancer. Right? So estrogen plus progesterone therapy जब भी हम किसी फीमेल को देते हैं, she has increased chances of breast cancer, and इसमें main culprit is progesterone. Are you understanding? And that is why HRT is given only for one indication, and that is severely affecting the life of a female, hot flushes which severely affect her life. राइट? तो अगर उसकी लाइफ के साथ इंटरफियर, उसकी डेली एक्टिविटीज के साथ, मेनोपॉजल फीमेल की डेली एक्टिविटीज के साथ हॉट फ्लशेस इंटरफियर कर रहे हैं, देन वी गिव एचआरटी. अदरवाइज हम एचआरटी नहीं देते हैं. वाई? बिकॉज एचआरटी अगर हम केवल ईस्ट्रोजन देंगे तो एंडोमेट्रियल कैंसर हो जाएगा. ईस्ट्रोजन प्लस प्रोजेस्टेरोन देंगे तो देयर विल बी इंक्रीज्ड चांसेस ऑफ ब्रेस्ट कैंसर. आर यू अंडरस्टैंडिंग दिस? Right. Now, which hormone is responsible for galactopoiesis or synthesis of milk? The answer is prolactin. Now they ask you, when do you see maximum levels of prolactin? Please remember, maximum levels of prolactin are not seen in the lactation period. Maximum levels of prolactin are seen in pregnancy. Then why is it कि प्रेगनेंसी में मिल्क की सिंथेसिस या गैलेक्टोपोइसिस उतनी नहीं हो रही है जितनी लैक्टेशन वाले पीरियड में हो रही है? दैट इज बिकॉज in females during pregnancy, placenta is forming estrogen and progesterone, and ये जो estrogen and progesterone होते हैं, they have a negative effect on the action of prolactin. Right? So they have an inhibitory effect on the action of prolactin. अब जैसे ही डिलीवरी होती है, प्लेसेंटा बाहर गया, ईस्ट्रोजन कम हो गया, प्रोजेस्टेरोन कम हो गया, तो जो उनका इनहिबिटरी इफेक्ट था ऑन द एक्शन ऑफ प्रोलैक्टिन वो चला गया. And that is why milk synthesis happens in the breastfeeding females. So if they ask you which is the first stimulus for breastfeeding, so many of you say कि first stimulus for breastfeeding is suckling of the breast or suckling of the nipples by the infant. That is wrong. The first stimulus for breastfeeding is decrease in estrogen and progesterone. क्योंकि estrogen progesterone जैसे ही नीचे जाता है, जैसे ही प्लेसेंटा बाहर आता है, वैसे ही negative effect on the action of prolactin is gone. राइट? सो प्रोलैक्टिन के लेवल्स मैक्सिमम नहीं होते लैक्टेशन में, लेकिन ईस्ट्रोजन एंड प्रोजेस्टेरोन का नेगेटिव इफेक्ट नहीं होता है ऑन प्रोलैक्टिन एट द टाइम ऑफ लैक्टेशन. राइट? इन प्रेगनेंसी प्रोलैक्टिन के लेवल्स मैक्सिमम होते हैं, बट बिकॉज ऑफ ईस्ट्रोजन एंड प्रोजेस्टेरोन देयर इज अ नेगेटिव इफेक्ट ऑन द एक्शन ऑफ प्रोलैक्टिन. क्लियर टू ऑल ऑफ यू? राइट. व्हिच hormone is responsible for milk ejection or galactokinesis, that is oxytocin. And all of you know that oxytocin also leads to uterine contractions, and that is why there is pain during breastfeeding, pain in abdomen during breastfeeding, क्योंकि uterus contract करना शुरू कर देता है because of the release of oxytocin. So which hormone is responsible for pain? और ये pain कहाँ पे होगा? Pain in abdomen होगा, uterine pain होगा during breastfeeding, that is oxytocin. Clear to all of you? Right. Coming to question number 10. How much is the recommended dose of folic acid in pregnancy with previous history of neural tube defect? So I know all of you know this answer. That अगर previous history होती है neural tube defect की, so the dose is 4 milligrams. Right? अब इसी question को they can ask you what is the dose of folic acid to prevent neural tube defect. So if your question is simply to prevent neural tube defect, then the dose is 400 micrograms per day, and this should be given to all pregnant females, right? And this should begin 1 month before conception. You should begin this dose 1 month before conception, and you should end it by 3 months after conception, right? But suppose if your question says what is the dose to prevent recurrence of neural tube defect, जैसे ही ये टर्म आ जाता है recurrence of neural tube defect, इसका मतलब है कि उस pregnant female में previous history है of a baby with neural tube defect. So whether they say that how much is the dose recommended for folic acid in pregnancy with previous history of neural tube defect, or if they say what is the dose recommended to prevent recurrence of neural tube defect, it's one and the same thing. So इसी question को if they ask in this format, then also the answer is 4 milligrams, right? 4 milligrams per day. Now, when should you begin this dose? This dose should be started as soon as the female thinks about conception. So जैसे ही ऐसी फीमेल कंसेप्शन के बारे में सोचना शुरू करे, she should start taking 4 milligrams of folic acid. Theoretical language is that this dose should be started 3 months before conception. 3 months before conception. But this is very theoretical. Now you only tell me, as a doctor, as a gynecologist, क्या आप किसी भी फीमेल को कभी भी ये बता सकते हो with surety कि आज से 3 months के बाद तुम pregnant हो जाओगी? नहीं, you cannot, right? So this is just a theoretical thing कि it should be started 3 months before conception. Clinically हम क्या करते हैं? हम कहते हैं whenever you think about conceiving, if you have a previous history of neural tube defect, जैसे ही सोचो कि भैया मुझे conceive करना है, start taking folic acid 4 milligrams. And again, ये जो 4 milligrams है, till how much time it should be taken? It should be taken till 3 months after conception. 3 months after conception, right? Now, there are few things which I want to clear over here. Suppose आपका question आता है that there is a pregnant female who's diabetic. What is the dose of folic acid recommended in her? कोई history नहीं है previous neural tube defect की, right? No history of previous neural tube defect. Just a simple question that a diabetic female, how much folic acid should you recommend to her? Whether she is gestational diabetes, whether she is overt diabetes. Please remember, diabetes, कैसी भी diabetes हो, dose remains the same, 400 micrograms per day, right? Unless and until previous history of neural tube defect, right? Now, if your question is that a pregnant female is on anti-epileptic drugs, what is the dose of folic acid recommended? 4 milligrams per day, right? And to treat megaloblastic anemia, what is the dose of folic acid? It is 1 milligram per day. Clear? Okay. Then what is the dose of folic acid in Anemia Mukt Bharat program? So Anemia Mukt Bharat program says that 1 red pill should be taken from 4th month onwards, and this 1 red pill will have 60 milligram of iron plus 500 micrograms of folic acid. So please remember, 3rd month तक तो हमने पेशेंट को कहा था, हर प्रेग्नेंट फीमेल को हमने कहा था कि she should take 400 micrograms of folic acid up till 3 months. And वो हम दे रहे थे to prevent neural tube defect. 4th month से हमने उसे कहा कि you should take 60 milligrams of iron and 500 micrograms of folic acid. अब ये जो 500 micrograms of folic acid है, this is not to prevent neural tube defect. 4th month से जो अनीमिया मुक्त भारत में हम दे रहे हैं, this is to prevent dimorphic anemia. So iron and folic acid deficiency anemia is very common in pregnancy. सो अनीमिया मुक्त भारत प्रोग्राम में हम आयरन ही केवल नहीं देते, हम फॉलिक एसिड भी देते हैं. सो दिस इज टू प्रिवेंट फॉलिक एसिड डेफिशिएंसी अनीमिया. प्लीज डू नॉट थिंक कि जो 4th मंथ से हम फॉलिक एसिड दे रहे हैं दैट इज टू प्रिवेंट न्यूरल ट्यूब डिफेक्ट. न्यूरल ट्यूब डिफेक्ट को प्रिवेंट करने के लिए हम केवल 3rd मंथ तक देते हैं. 4th मंथ से हम 1 रेड पिल देते हैं टू प्रिवेंट डायमॉर्फिक अनीमिया, आयरन एंड फॉलिक एसिड डेफिशिएंसी अनीमिया. Next very important question is, what is the recurrence rate of neural tube defect after one affected child? It is 5% and after 2 affected children it is 10%. चाहे anencephaly हो या कोई भी neural tube defect हो, 5% is after 1 and 10% after 2. Now neural tube defects में they can ask you in anencephaly that what is the earliest time at which anencephaly can be detected on ultrasound? Earliest it can be detected on ultrasound by 10 weeks. And best it can be detected by 14 weeks on ultrasound. They can ask you what is the best or the most specific biochemical marker to detect neural tube defect. Most specific or best biochemical marker to detect neural tube defect. Please do not say HCG. HCG is not the best biospecific marker or biochemical marker. Which is the best biochemical marker? Tell me quickly in the chat box. I'm just waiting for your answer. I'm not getting any answers. Anyone? Best biochemical marker or most specific biochemical marker? It's not alpha fetoprotein. Excellent, Monica. It is acetylcholine esterase. That's the most specific biochemical marker, right? Or the best biochemical marker. Question number 11, again a very straightforward question. Minimum number of antenatal visits as recommended by WHO. So repeatedly I have been telling you that the minimum number of antenatal visits by WHO have changed from 3 to 8. So please remember, Government of India के according minimum number is 4. WHO के according minimum number is 8 and ideal number is 12 to 15, in which till 28 weeks you have to do one visit every 4 weeks. Between 28 to 36 weeks, one visit every 2 weeks, and at more than 36 weeks, one visit every week. Right? Now, WHO कहता है 8, and इसमें you don't have to remember that at what time these 8 visits should be taken. You just have to remember one visit in first trimester, 2 visits in second trimester, and 5 visits in third trimester. Right? Okay. Which of the following is the safest drug to be used for pregnancy-induced hypertension? Safest पूछा है. So please remember, if your question is what is the drug of choice for PIH? The drug of choice for PIH is labetalol. If they ask you what is the drug of choice for chronic hypertension in pregnancy, this answer has changed. For chronic hypertension in pregnancy, it is alpha methyl dopa. That's the best answer. Alpha methyl dopa nahi diya hai, then labetalol. If they ask you safest antihypertensive, again it is alpha methyl dopa, right? Now please remember that alpha methyl dopa is a slow acting drug. That is why it cannot be used in hypertensive crisis. What is hypertensive crisis? Hypertensive crisis is when BP becomes more than equal to 160 by 110. Right? That is hypertensive crisis. And hypertensive crisis mein drug of choice is IV labetalol. You cannot use methyl dopa. If IV labetalol is not available, then you can use IV hydralazine. Right? The most common side effect of alpha methyl dopa is drowsiness. It may lead to mild psychosis or depression in the patient, and it is one of the reasons for a false positive Coombs test in Rh negative females. So it leads to a false positive Coombs test. Now, when should you start antihypertensive in a pregnant female? You should start antihypertensive if you get even one reading as more than 160 by 110. You should immediately start antihypertensive, or if you are getting 2 or more readings of more than 150 by 100. So if you are getting persistently increased BP more than equal to 150 by 100, then you should start antihypertensive. Or even if you are getting a single reading as 160 by 110, because 160 by 110 means hypertensive crisis, then you should start antihypertensive, right? A very important question is, which antihypertensives are contraindicated in pregnancy? All of you know it is ACE inhibitors, captopril, enalapril, then angiotensin receptor blocker like losartan, then diazoxide, diuretics, and beta blockers. Please remember that diuretics, they can be used by a pregnant female with heart disease. It is contraindicated as an antihypertensive. But in heart disease patients, if there is pulmonary edema and you want to use diuretics, you may use it. But as an antihypertensive, it's absolutely contraindicated, right? So over here, which of the following drug is safest to be used for pregnancy? As I told you, safest drug is methyl dopa. So the answer is methyl dopa. Clear to all of you? Okay. Then, now this was a very vague question, but still we are going to answer it. A patient presents with a positive UPT. In which of the following conditions we will have to assess pregnancy test repeatedly? Now, pregnancy tests are based on HCG values. And just now we were saying that once you evacuate a molar pregnancy, you have to follow up HCG values, right? So over here, the best possible answer is molar pregnancy. For gender identification, actually gender identification is not allowed in India. And for gender identification, we don't need HCG value. For fetal health status, we don't need HCG value. For following up an Rh incompatibility patient, what do you do? In Rh incompatibility patient, you will do an indirect Coombs test, and if indirect Coombs test comes out to be positive, then you are going to follow up with what? You are going to follow up with peak systolic velocity of middle cerebral artery Doppler. You are going to follow up with peak systolic velocity of middle cerebral artery Doppler. It is not visible there. I'll write it here. Peak systolic velocity of middle cerebral artery Doppler. So that is how you follow up an Rh negative pregnancy. You do an indirect Coombs test, and if indirect Coombs test comes out to be negative, then you go for peak systolic velocity of middle cerebral artery, right? Doppler. Clear? Okay. Question number 14. Most common neonatal complications of gestational diabetes. Now, please remember that neonatal complications. So, in case of diabetes in mother is going to have hyperglycemia, right? This is going to go to the fetus. So, fetus will have hyperglycemia. Because of this hyperglycemia, fetus will secrete insulin. So, there will be hyperinsulinemia, and this hyperinsulinemia is going to lead to big size baby, macrosomia. Now, when the baby will be born, when the neonate will be born, the connection between mother and baby will be gone, right? So, the source of glucose is gone. But what remains in the neonate is hyperinsulinemia. And because of this hyperinsulinemia, there is hypoglycemia. All of you know that. Right? So, the most common neonatal complication of neonate of a diabetes, whether it is gestational diabetes or overt diabetes, it is hypoglycemia. Apart from hypoglycemia, there is hypokalemia, hypocalcemia, and hypomagnesemia. Right? Then there is hyperviscosity syndrome. This hyperviscosity syndrome consists of polycythemia plus hyperbilirubinemia. Right? Then there are chances of respiratory distress syndrome, necrotizing enterocolitis, neonatal sepsis, and cardiomyopathy. So these are all the neonatal complications which can happen in diabetes. Please remember, in babies of diabetic mother, so in neonates, you will never get, in neonates who are born to be diabetic mothers, you will never get, number one, hyperglycemia. You will always get hypoglycemia. Number two, you will never get anemia, right? Because they have polycythemia, right? And number three, you will never get mental retardation. So these babies, they have a few cognitive defects, they have a few delayed milestones, right? They are prone to autism, right? So please remember, they have some cognitive defects might be present. They may face some difficulty in language development. Their milestones may be a little delayed. Autism can be seen in babies of diabetic mother, but babies of diabetic mother are never mentally retarded, right? So if they give you a list of complications, all of the following are seen in babies of diabetic mother or neonates of diabetic mother, except, in that except, you have to look for these three. Except you will never get hyperglycemia, never get anemia, never get mental retardation, right? Now, respiratory distress syndrome or hyaline membrane disease, yes, it is common. Why it is common? Because of two reasons. Number one, because of preterm labor. Because in diabetes, there is polyhydramnios. Polyhydramnios can lead to preterm labor. Number two, insulin decreases the surfactant synthesis. Right? So yes, hyaline membrane disease or respiratory distress syndrome, it is seen, but it is not the most common complication. Most common complication is hypoglycemia. That reminds me, if they ask you, what is the best lung maturity test for babies of diabetic mother? Best lung maturity test for babies of diabetic mother. Please do not say it is lecithin upon sphingomyelin ratio. It is not the best test. Best test, whether they ask in babies of diabetic mother or non-diabetic mother, best lung maturity test always is phosphatidylglycerol. Phosphatidylglycerol. That's the best test, best lung maturity test. If phosphatidylglycerol is present, lungs are mature. If it is present in amniotic fluid, lungs are mature. If it is absent in amniotic fluid, lungs are not mature, right? So these are questions which are related to babies of diabetic mother. Congenital malformations are not seen in gestational diabetes. All of you know that. It is seen in overt diabetes. Then a 26-year-old primary gravida with 12 weeks period of gestation attends the antenatal clinic with history of lower quadrant pain and fever. Her ultrasound shows appendix 10 millimeters thick. The moment they say appendix is 10 millimeters thick, we know they are talking about appendicitis. WBC count is 18,000. Which of the following is done? So here we have a surgery and OBGY integrated question, where they are asking you about appendicitis in pregnancy. Please note down the important points related to appendicitis in pregnancy. Appendicitis in pregnancy is the most common surgical problem which is seen in pregnancy. Now, if they ask you, is the incidence of appendicitis increased in a pregnant female? No. The incidence is not increased, rather appendicitis is seen less in pregnant female. But suppose a female already had appendicitis, right? Then the chances of complications due to appendicitis are increased in pregnancy, right? So morbidity, agar appendicitis ho gaya pregnancy mein, normally the chances of appendicitis are decreased in pregnancy or they are not increased. But agar ho gaya appendicitis in pregnancy, tab morbidity due to appendicitis is going to be increased in pregnancy. Most common time for appendicitis in pregnancy is second trimester. Most common time of perforation of appendix in a pregnant female is third trimester. Now classic presentation will be patient आपको complain करेगी pain in abdomen का, जो कि right lower quadrant pain होगा within few centimeters of McBurney's point. And later on, जैसे जैसे uterus enlarge करेगा, this pain is going to shift. And the pain is going to be felt in the mid or upper quadrant. So there will be a history of shifting pain as well. There could be a history of shifting pain as well. There can be associated nausea, vomiting and fever. And because the enlarging uterus is going to move the peritoneum away from the area of inflammation, so normally जो appendicitis में बहुत clear cut guarding मिलता है, बहुत clear cut rebound tenderness मिलता है, वो pregnancy में नहीं मिलेगा because the enlarging uterus is going to shift the peritoneum away from the inflamed appendix. So you're going to get less guarding and less rebound tenderness. Now, pain in abdomen, है ना, साथ में nausea, vomiting, all these are sometimes common features in pregnancy as well. Right? फिर उसके बाद जब आप investigation करोगे, appendicitis में investigations में क्या मिलता है? WBC count raised मिलता है, जो कि नॉर्मली भी प्रेगनेंसी में रेज्ड मिलता है. इन नॉर्मली ऑल्सो इन प्रेगनेंसी TLC कैन गो अप टिल 15,000, राइट? So that is why diagnosing appendicitis in pregnancy is little tricky. This suspicion you should always keep in mind. This differential diagnosis you should always keep in mind whenever a pregnant female comes to you with pain in abdomen. Right? And whenever a pregnant female comes to you with pain in abdomen, you should go for the investigation of choice, which is a compression ultrasound. On compression ultrasound, you will see that there is a non-compressible structure, and that non-compressible structure is appendix. And if it is more than 6 millimeters in diameter, your diagnosis for appendicitis is confirmed. Just in case you are unable to confirm the diagnosis on ultrasound, then the gold standard investigation is MRI. अब यहाँ पे 10 millimeters thick मिल रहा है. So I know it is a case of appendicitis in pregnancy. Now comes the golden question कि अगर appendicitis हो गया pregnancy में, how am I going to manage it? Now whenever appendicitis happens in pregnancy, you have to go for immediate appendicectomy. Why? Because अगर appendix rupture कर गया, it will lead to increased maternal mortality and morbidity and increased fetal loss. इसीलिए हम appendicitis के केस में कभी भी ये नहीं कहेंगे कि wait and watch या केवल antibiotics दे दो. No. Immediate appendicectomy has to be done irrespective of the gestational age. Along with appendicectomy, yes, I'm going to give her antibiotics and I'm going to give her tocolytics. That is the management of appendicitis in pregnancy. Right? So over here, which of the following is done? CECT कभी नहीं करेंगे pregnancy में for diagnosing appendicitis. Investigation of choice is ultrasound and gold standard is MRI. Antibiotics and appendicectomy after 20 weeks? No. Immediate करना है. 12 weeks पे आइए. I'm not going to wait till 20 weeks. Osner-Sherin regime? No. Antibiotics and immediate surgery? Yes. That is the management. Now, after this session is complete, I want all of you to pause this slide. I have written about gallstones in pregnancy also a few points. So, I want you to note down a few points about gallstones in pregnancy also. Right? Okay, so all those who are Marrow subscribers, if you go to the Delta videos, in Delta videos, I have included appendicitis in pregnancy, pancreatitis in pregnancy and gallstones in pregnancy. अगर question appendicitis पे आ गया, next time gallstones या pancreatitis पे भी आ सकता है, right? So go to the Delta videos and write down about gallstones in pregnancy and pancreatitis in pregnancy. Question number 16. A patient went for radiotherapy for cancer cervix. Which part will be the most radiosensitive? So all of you know that कि most radiosensitive structure in pelvis are gonads. That is the ovaries and the testes. Most radio-resistant structure is vagina. Right? Now the contradictory part is that although ovaries are the most radio-sensitive structure, but the ovarian cancers are radio-resistant. Right? So ovarian cancers का treatment कभी भी chemotherapy नहीं होता. Right? Sorry, कभी भी radiotherapy नहीं होता. Ovarian cancers are radio-resistant. They are you never treat them by radiotherapy. You will have to treat them by surgery and chemotherapy. There is only one ovarian cancer which is radiosensitive. And what is the name of that cancer? Dysgerminoma. Dysgerminoma. That's the only radiosensitive ovarian tumor, right? Now, in cancer cervix, ovarian metastasis happens in less than 1% cases. That is why जब भी हम surgery करते हैं for cancer cervix in a young female, so even if we are doing radical hysterectomy or Wertheim's hysterectomy, we never remove the ovaries, right? Because this metastasis to ovaries is very less in cancer cervix. If next very important questions which they can ask you are, what is the sentinel lymph node for cancer cervix? The sentinel lymph node for cancer cervix is paracervical lymph node. If paracervical is not given in the options, then ureteric lymph node. But if they ask you, what is the most common lymph node involved in cancer cervix? Most common lymph node involved in cancer cervix is obturator lymph node. But again, cancer cervix pe, there were 3 questions. 2 related to HPV and 1 related directly to cancer cervix. So cancer cervix becomes a very important topic for you for your upcoming FMGE exams, right? Now, in staging of cancer cervix, I just want you to remember a few very important concepts. Ideally, cancer cervix ki staging tips pe honi chahiye. But these are the points which you have to focus on in cancer cervix staging. Pelvic lymph node is involved in stage 3C1, para-aortic in 3C2, superficial inguinal in stage 4B. Please remember, whether it is endometrial cancer, whether it is ovarian cancer, or whether it is cervical cancer, in all these 3 cancers, superficial inguinal lymph nodes are involved in stage 4B. Kidney and ureter are involved in stage 3B, but bladder is involved in stage 4A, right? Ovarian involvement and uterine involvement do not change the staging of cancer cervix. तो cancer cervix की staging में कभी भी ovarian involvement का details नहीं दिया है या uterine involvement की details नहीं दी है. They are not included as a part of staging of cancer cervix. Even if the cancer cervix has involved the ovaries or the uterus, the stage remains unchanged. Right? Clear to all of you? Then important points on radiotherapy in cancer cervix. Please remember, cancer cervix जो मोस्ट कॉमन वैरायटी होती है कैंसर सर्विक्स की, दैट इज स्क्वामस सेल कार्सिनोमा. एंड स्क्वामस सेल इज अ लिटिल रेजिस्टेंट टू रेडियोथेरेपी. So to make the squamous cells radio sensitive, you add a radiosensitizer, and that radiosensitizer is cisplatin. So in case of cancer cervix, we use not just radiotherapy, we give cisplatin plus radiotherapy, and that is why it is better to call it as chemoradiation. Right? So chemoradiation is the treatment of choice from stage 2A2 of cancer cervix. So 2A2 से लेके 4B तक you go for chemoradiation. What is chemoradiation? You will give cisplatin followed by radiotherapy. One very common mistake which all of you do. Suppose अगर वो question देते हैं आपको कि stage 3A1 में what is the treatment of choice, and your options are option A radiotherapy, option B chemotherapy, option C surgery, option D hormonal therapy. Now tell me, what will your answer be? Quickly tell me, what are you going to answer? Management of choice in stage 3A1 of cancer cervix. And your options are A radiotherapy, B chemotherapy, C surgery, and D hormonal therapy. I'm waiting for your answers. Just one answer I've got. Where are more answers? No, it's not a recorded video, beta. Aditya has written chemo. Chemo. No. All those who are writing chemo, you are not correct. देखो जो हम सिस्प्लेटिन दे रहे हैं वो कीमोथेरेपी की तरह नहीं दे रहे हैं, वो केवल सेल्स की सेंसिटिविटी को बढ़ा रहा है, वो मेलिग्नेंट सेल्स पे एक्ट नहीं कर रहा है, राइट? सो अगर कीमो रेडिएशन ऑप्शन में नहीं है, योर आंसर विल बी रेडियोथेरेपी एंड नॉट कीमोथेरेपी. दैट इज व्हाई आई टोल्ड यू दिस आंसर. ठीक है, कभी भी ये नहीं कहोगे कि कैंसर सर्विक्स में कीमोथेरेपी इज द ट्रीटमेंट ऑफ चॉइस. नो, इट इज कीमो रेडिएशन. अगर कीमो रेडिएशन नहीं दिया है then it is radiotherapy. From stage 2A2 to stage 4B, management is chemo radiation. That's the best answer. वो नहीं दिया है तो radiotherapy. Please, for God's sake, do not do this mistake and do not say chemotherapy as the answer. Clear to all of you? कार्तिक स्टेज 3A1 में सर्जरी नहीं है बेटा. 2A2 से लेके स्टेज 4 तक कीमो रेडिएशन आंसर होता है, एंड अगर कीमो रेडिएशन नहीं दिया है तो रेडियोथेरेपी आंसर होता है, राइट? सर्जरी यूज होती है इन अर्ली स्टेजेस ऑफ कैंसर सर्विक्स. फ्रॉम स्टेज 2A2 ऑनवर्ड्स यू यूज कीमो रेडिएशन, राइट? ओके, अच्छा. नाउ व्हेन वी आर टॉकिंग अबाउट रेडियोथेरेपी, रेडियोथेरेपी कैन बी ऑफ टू टाइप्स, ब्रैकीथेरेपी और टेलीथेरेपी. डिफरेंस क्या होता है? ब्रैकीथेरेपी में जो सोर्स ऑफ रेडिएशन होता है दैट इज केप्ट इनसाइड द फीमेल्स बॉडी. टेलीथेरेपी में द सोर्स ऑफ रेडिएशन इज केप्ट आउटसाइड द बॉडी. सो इन केस ऑफ कैंसर थेरेपी वी यूज बोथ ब्रैकी एंड टेलीथेरेपी. ब्रैकीथेरेपी में देयर आर टू इंपॉर्टेंट पॉइंट्स व्हिच यू हैव टू रिमेंबर, पॉइंट ए एंड पॉइंट बी. Point A is a point which is 2 centimeters above the external os and 2 centimeters lateral to it. So A is a point which is 2 centimeters above the external os. Look over here, all of you. 2 centimeters above the external os and 2 centimeters lateral to it. And point B is a point which is 3 centimeters lateral to point A. तो एक्चुअली पॉइंट बी कहां पे हो गया? 2 सेंटीमीटर्स अबव द एक्सटर्नल ऑस एंड 5 सेंटीमीटर्स लेटरल टू इट. सो दीज आर टू इंपॉर्टेंट पॉइंट्स व्हिच हैव टू बी रिमेंबर्ड व्हेन यू आर गिविंग ब्रैकीथेरेपी. द डोज ऑफ ब्रैकीथेरेपी व्हिच यू यूज इन केस ऑफ कैंसर सर्विक्स इज 10,000 सेंटीग्रेड. आउट ऑफ दिस 10,000 सेंटीग्रेड, पॉइंट ए को जाना चाहिए 8,000 to 9,000 सेंटीग्रेड एंड पॉइंट बी को मिलता है 6,000 to 7,000 सेंटीग्रेड. Point A वो point है जहां पे uterine artery crosses the ureter and generally the paracervical or the ureteric lymph nodes are present there. And point B is that point where obturator nodes are present. So as I told you, the sentinel lymph node is ureteric lymph node or paracervical lymph node. That is where point A is present. And the most common lymph nodes are obturator lymph nodes. So that is the target point, point B, where obturator nodes are present. Clear to all of you? Yes? Okay. Next question on cancer cervix. Which of the following can cause cervical cancer? Now again a very, very easy question. All of you know that HPV 6 and HPV 11, they will lead to genital warts or they may lead to laryngeal papillomas. Right? It is HPV 16 and HPV 18 which are the most common ones causing cancer cervix. So the most common HPV causing cancer cervix is HPV 16. Most specific is HPV 18. Most common HPV causing squamous cell cancer. S for squamous, S for 16. So it is HPV 16. Most common causing adenocarcinoma. HPV 18. Now, HPV which is responsible for genital warts or laryngeal papillomas, HPV 6 and HPV 11. In HPV, certain proteins are present. Which proteins are important for viral replication? E1 and E2 proteins. Which proteins are responsible for malignant transformation? E6 and E7. E6 knocks out P53 tumor suppressor gene. And E7 is going to knock out retinoblastoma gene. अगर ये पूछा जाए कि one protein which is the most important for malignant transformation, that is E7. दोनों E6 and E7 important है, but out of them if you have to choose one, it is going to be E7. Now for making vaccines, it is L1 capsid protein. Right? all of you know that HPV vaccines are available, जिसमें Gardasil 9 is the most commonly used these days. So recently, Gardasil 9 has been approved for ages 26 to 45 years also. Right? तो इसका मतलब क्या हुआ? पहले हम देते थे 9 years to 26 years. अब हम क्या कर सकते हैं? From 9 years to 45 years, we can give Gardasil 9. ये जो 26 to 45 years है, this is on the discretion of the gynecologist. अगर gynecologist को लगता है कि 26 to 45 years की female has got a lot of high risk factors which can lead to cancer cervix, so now Gardasil 9 can be given between 26 to 45 years also. So overall जो range हो गई है Gardasil 9 की, it has increased from 9 years, it can be given up till 45 years. But that doesn't mean that every female between 26 to 45 I'm going to give Gardasil 9. Right? It is only depending on the high risk factors. Now what is the ideal age? Ideal age is 11 to 12 years. Clear? Please remember, you can never give Gardasil or HPV vaccines. They can never be given less than 9 years pe, and they can never be given to pregnant females. Right? So you can never give HPV vaccine to a pregnant female. You can never give it to a female who is less than 9 years of age. Clear to all of you? Yes, that is again an update which I wanted to share with you. I've already shared so many times. So over here, there is no confusion. You don't have HPV 16 over here. You only have HPV 18. So my answer is going to be HPV 18. Clear? Now, the third question which was asked on cancer cervix was, filter which is used in colposcopy is. Now, these are screenshots from direct marrow notes, although all questions I have done there, but specifically a few things I wanted to show you from marrow notes itself. Now, colposcope is a magnifying instrument, and colposcope magnifies the cervix by 30 times. So, this is how a colposcope looks like. ये एक मैग्नीफाइंग इंस्ट्रूमेंट होता है जो कि सर्विक्स को 30 टाइम्स एनलार्ज कर देगा, राइट? कॉल्पोस्कोपी इज एन ओपीडी प्रोसीजर. नाउ जब आप कॉल्पोस्कोप से सर्विक्स को देखते हो, द अपर पार्ट ऑफ द सर्विक्स कैन नॉट बी सीन. इन अदर वर्ड्स, एंडो सर्विक्स कैन नॉट बी सीन. नाउ सपोज अ पैप स्मेयर रिपोर्ट कम्स आउट टू बी abnormal. तो जब भी पैप स्मेयर रिपोर्ट abnormal आती है, we do a colposcopy. And again, this is very important. I want all of you to go and watch the VR with you session and the OBGY pathology integrated session, which are present on Marrow's YouTube channel. In both these sessions, I have told you in detail कि पैप स्मेयर रिपोर्ट जब abnormal आएगी तो उसको कैसे मैनेज करोगे. So abnormal pap smear reports, what is the next step? That is very, very important, and that I have told in detail in those two videos, right? So whenever pap smear report comes out to be abnormal, you are going to do a colposcopy, and colposcopy say first you are going to take out biopsy from any rough area. Then you are going to apply 3 to 5% acetic acid, and you are going to take biopsy from aceto-white areas, those areas which appear white. Then you are going to switch on the green filter, and you are going to take biopsy from abnormal blood vessels. These abnormal blood vessels can be a mosaic blood vessel, a reticular blood vessel, or a punctate blood vessel. So this is how colposcopy is done. A report of pap smear comes as LSIL or HSIL or ASCUS. Whereas report of colposcopy या colpobiopsy comes as CIN1, CIN2 and CIN3. कभी भी पैप स्मेयर की रिपोर्ट के बेसिस पे हम मैनेजमेंट नहीं करते हैं. मैनेजमेंट करते हैं हम ऑन द बेसिस ऑफ रिपोर्ट ऑफ colposcopy. Never based on pap smear. Pap smear is just a screening method, right? So based on pap smear, you are never going to do management. Management has to be done only after colposcopy confirms that it is a case of CIN1, CIN2 or CIN3. How do you manage CIN1? CIN1 you have to observe for 2 years. Normally it is going to regress in 2 years. If it persists for more than 2 years, you are going to do a cryoablation. And management of CIN2 and CIN3 at any age. कोई भी age हो, कोई भी parity हो. So whether they say a female is 45 years of age, 55 years of age, she has 2 children, 4 children, 10 children, irrespective of that, management is LEAP or LLETZ. Large loop excision of transformation zone or loop electro-excisional procedure. Clear to all of you? Yes? Okay. Question number 19. Question number 19 is management of decubitus ulcer in uterine prolapse is. So option A, laser ablation, option B, hysterectomy, option C, packing, and option D, antibiotics. Okay, so question 18 ka answer, what was the answer? It was a green filter. Coming to question number 19, management of decubitus ulcer in uterine prolapse is. Now, see why this ulcer happens. Why is ulcer happening in a patient of prolapse, the decubitus ulcer? I've told you in the lectures also that when the uterus hangs out, then the venous return decreases. Because venous return decreases, there is venous congestion. And it is this venous congestion which is going to lead to decubitus ulcer. Right? So, अब ये जो venous congestion होगा, ये वीनस कंजेशन को रिलीव करने के लिए हम क्या करेंगे, हम यूट्रस को थोड़े से टाइम के लिए उसकी नॉर्मल पोजीशन पे लाएंगे सो दैट द वीनस रिटर्न इज फैसिलिटेटेड. एंड हाउ एम आई गोइंग टू डू दैट? आई एम गोइंग टू डू इट विद द हेल्प ऑफ packing. Right? I am going to go for acreflavin and glycerine packing. Acreflavin is a yellow colored hygroscopic agent. Right? It's a yellow colored hygroscopic agent, and glycerine is a sorry. I'm getting disturbed because I can see that you people, in your case, the slide has not changed. Why is the slide not changing in your? Please tell me, can you all see the question number 20 slide there? It is stuck. Can you see slide number 20? Question number 20, please, all of you. Somehow I feel there is a glitch over here because I can see all of you writing the answer as packing and the slide is got stuck to cancer cervix slide. Just let me close and open it. I'm just closing and opening it. Okay. Now, bacho, can you see the slide? Okay, so you can see. Okay. So please remember, acreflavin is a yellow colored antiseptic liquid, antiseptic solution, and glycerine is a hygroscopic agent. Right? So you are going to do packing with acreflavin and glycerine. Right? Now, one very important thing which they can also ask you apart from decubitus ulcer and management of prolapse is senile vaginitis, and that is something which I want to tell you. What is senile vaginitis? Senile vaginitis is vaginitis which is seen in elderly females, and that is menopausal females. Right? So it is the dryness of vagina which is happening due to decreased estrogen. Now, one very common mistake which you all do is, if they ask you what is the treatment of choice for senile vaginitis, what is the treatment of choice for senile vaginitis? Tell me. First choice, write in your note, write in the chat box, what is the treatment of choice? First line management of senile vaginitis, what is it? Anyone in the chat box can tell me first line management of senile vaginitis? I am not seeing your answers. Hormonal. Okay. Anyone else? Estrogen. Okay. Estrogen. Premarin. Okay. And that is why I wanted to take up this over here. Please remember, first choice management of senile vaginitis is not estrogen. It is vaginal lubricants. Do not answer it as estrogen. Second choice is local estrogen cream. In other words, HRT. And third line management is a selective estrogen receptor modulator drug called as ospemifene. Ospemifene. Right? So this is the order in which you are going to remember. The best management or the first line management of senile vaginitis is vaginal lubricants. Second line management is local estrogen cream. And so many times तुम लोग को ऐसा लगता है कि अगर estrogen orally लिया जाए तभी उसको HRT बोलते हैं. Please do not be in this misconception. Estrogen चाहे locally cream के form में लिया जाए, चाहे orally लिया जाए, it comes under HRT. So the second choice drug is HRT, that is local estrogen cream, and the third choice drug is ospemifene. This is the order in which you have to remember, and I knew you are going to do mistake. That is why I told you this over here. Coming to next question. A multiparous female patient complains of dribbling of urine during coughing and laughing. She is having normal micturition as well. What is the most likely cause? अब यहाँ पे उन्होंने clear cut hint दिया है that there is incontinence of urine which is happening due to increased intra-abdominal pressure. So whenever there is a incontinence of urine due to increased intra-abdominal pressure, like laughing, coughing, sneezing, that is what is called as SUI or stress urinary incontinence. Stress urinary incontinence is the most common type of urinary incontinence in females. It will be seen in elderly females and it is also seen in prolapse. Right? Now, suppose if your patient is having a severe urge to pass urine, right? So she has a severe urge to pass urine, right? And by the time she goes to pass urine, there is incontinence. There is dribbling of urine, right? That is what is urge incontinence. This is seen due to detrusor overactivity. Right? So patient will have a severe urge to pass urine and then by the time she goes to pass the urine, there will be dribbling of urine. The third kind of incontinence, which is overflow incontinence, is patient is going to say that after passing urine, for some time, she has dribbling of urine. Right? So she has already evacuated her bladder. Evacuation के बाद, urination के बाद, when she gets up, उसके थोड़े time बाद तक भी she has a dribbling of urine. That is what is overflow incontinence, which is happening due to incomplete bladder emptying. And this is seen when there is detrusor inactivity or it is seen in bladder outlet obstruction. Right? So this is happening because the bladder is not getting emptied properly. Then, what is the problem? What is the complaint with which the patient is going to come to you in case of urinary fistulas? In case of urinary fistulas, patient continuously dribbling of urine की complaint करेगी. Continuous 24/7 she will have dribbling of urine. And dribbling of urine के साथ अगर normal act of micturition present है, so she has continuous dribbling of urine all throughout 24 hours, plus वो normally भी urinate कर रही है, then it is a case of ureterovaginal fistula. But continuous dribbling के साथ कोई normal urination नहीं है. She says, I cannot urinate normally, I'm just having continuous dribbling of urine. Then that is vesicovaginal fistula. So these are the kinds of complaints which you are going to get in urinary complaints, which you are going to get in overflow incontinence, in vesicovaginal fistulas, stress incontinence. So this over here is a case of स्ट्रेस इनकॉन्टिनेंस। अब अगर उन्होंने आपसे क्वेश्चन कर लिया है ऑन स्ट्रेस इनकॉन्टिनेंस, द नेक्स्ट वेरी इंपॉर्टेंट क्वेश्चन विच दे कैन आस्क यू इज स्ट्रेस इनकॉन्टिनेंस इज सीन इन, एज आई टोल्ड यू, इट इज सीन इन पेशेंट्स ऑफ प्रोलैप्स एंड इन एल्डरली फीमेल्स। एंड थर्ड थिंग विच दे कैन आस्क यू इज मैनेजमेंट ऑफ स्ट्रेस इनकॉन्टिनेंस। इसके अलावा स्ट्रेस इनकॉन्टिनेंस में यू डोंट हैव टू नो एनीथिंग. Now, I just need to tell you two important principles of managing stress incontinence, and stress incontinence surgeries are very easy after that. See, look at image A and look at image B. In image A, which is a normally placed bladder and urethra, when intra-abdominal pressure is increasing, right, it automatically is closing the bladder neck, right? So normally there is no stress incontinence because when intra-abdominal pressure increases, automatically the bladder neck gets closed. But suppose if bladder neck descends down, as is happening in image B, then in that case what is going to happen? Because bladder neck has descended down, now when intra-abdominal pressure is increasing, the bladder neck is not closing and it is leading to SUI. This means कि जो problem हो रही है SUI में वो ये हो रही है that the bladder neck is coming down. In other words, हमें क्या करना है? हमें bladder neck को elevate कर देना है and our problem will be solved. That is all what you have to do. Right? So if I want to elevate bladder neck, I can either go for abdominal surgeries or I can go for vaginal surgeries. Common sense tells me कि vaginal surgeries are easier to perform. Right? Abdominal surgery जब हम करेंगे तो हम upper part of urethra को lift करेंगे. And जब हम vaginal surgery करेंगे तो हम middle part of urethra को lift करेंगे. Are you understanding? Right? So look over here. Management of SUI is to lift the bladder neck. You can do this by vaginal surgeries or you can do this by abdominal surgeries. In vaginal surgeries, you are going to lift the middle urethra. They are daycare surgeries. No admission is needed and they are most commonly performed. And vaginal surgeries mein, there are two surgeries, TOT and TVT. TOT stands for tension-free transobturator tape. TVT stands for tension-free transvaginal tape. Right? तो अब TVT और TOT में हम क्या कर रहे हैं? हम middle part of urethra को tape से suspend कर रहे हैं. Right? In TOT हम obturator foramen के through उस tape को लेके जा रहे हैं. In TVT हम retropubic space में tape को लेके जा रहे हैं. So in TVT you are entering retropubic space. In TOT you are not entering retropubic space. Because TVT में हम retropubic space में enter कर रहे हैं, there are increased chances of bladder injury and there are increased chances of injury to venous plexus. There is a venous plexus which is present in the retropubic space. TOT में ऐसी कोई प्रॉब्लम नहीं है. So common sense कहता है कि if I ask you कि TOT and TVT में से which one will be preferred, you will say ma'am TOT will be preferred. So that means the most commonly done surgery for SUI, your answer will be TOT followed by TVT. Clear? अब abdominal surgeries. Abdominal surgeries में you are going to lift the proximal part of urethra and you are going to suspend it. You are going to put, going to attach it to the Cooper's ligament. So proximal part of urethra को attach कर देते हैं, suspend कर देते हैं to the Cooper's ligament. Look over here. Look at needle A. Needle A is passing through the proximal part of urethra and this over here is your Cooper's ligament. So needle A is passing through. So this over here is needle A, which is attaching the proximal part of urethra to the Cooper's ligament. And this surgery is called as Bursch-Kolpo suspension. This is the gold standard surgery for managing SUI. तो गोल्ड स्टैंडर्ड या बेस्ट सर्जरी होती है बर्च कॉल्पो सस्पेंशन. मोस्ट कॉमनली डन होती है टीओटी फॉलोड बाय टीवीटी. इज दैट क्लियर? Abdominal surgery है Birch Colpo suspension. It gives very good results. But the problem is admission will be needed and it's a big major surgery. TVT and TOT are minor surgeries, daycare surgeries. So they are most commonly done. Clear to all of you? Yes? Okay. That is all what you have to know on SUI. Coming to the next question, which is a very, very easy one. A female presents with grayish-white discharge. There is presence of clue cells and a positive whiff test. Which drug should be given in treatment? So if you are getting a grayish-white discharge with clue cells and a positive whiff test, definitely you know it is a case of bacterial vaginosis. And the drug of choice for bacterial vaginosis is metronidazole. So जब भी question देते हैं on discharge per vagina, you will have to guess that which discharge they are talking about. And these are the clues which are going to tell you that which discharge they are talking about. In case of bacterial vaginosis, the discharge will have a foul smell. That is very, very important. It will be a dirty white discharge. There will be no pruritus, no urinary symptoms. Now, नीट में क्वेश्चन दिया गया था कि देयर इज अ फीमेल विद व्हाइट डिस्चार्ज, नो फाउल स्मेल, नो प्रूराइटिस एंड नो डिसयूरिया. Then that is not bacterial vaginosis. Bacterial vaginosis is a bacterial infection. तो foul smell होगा ही होगा, right? So if you are getting white discharge, no foul smell, no pruritus, no dysuria, then it is a case of leukorrhea or physiological discharge. So the difference between physiological discharge and bacterial vaginosis is both of them are white in color. दोनों में pruritus नहीं होती, दोनों में urinary symptoms नहीं होते. But bacterial vaginosis में foul smell होता है, and in leukorrhea there won't be any foul smell. Then in case of bacterial vaginosis, pH of the discharge will be more than equal to 4.5. You will get words like Amsel's criteria is getting fulfilled. Whiff test will be positive. Clue cells will be present. What are clue cells? Clue cells are vaginal epithelial cells to which the bacteria are adhered. Vaginal epithelial cells to which the bacteria are adhered. Right? And these clue cells, they will be more than 20% of the epithelial cells. So if you get words like these, you come to know that they are talking about bacterial vaginosis. Bacterial vaginosis is a polymicrobial infection. इसमें क्या होता है? तो original Doddeline bacilli, they get replaced by Gardnerella vaginalis, Peptostreptococci, Mobilincus, and many other organisms. Right? When they have to tell you about trichomonas, the words which you have to look at are, in trichomonas you will get a frothy yellowish discharge. Frothy word will be there, yellowish discharge hoga, pruritus present hogi, dysuria present hoga, dyspareunia present hoga. pH of the discharge will be again be more than 4.5. They will give you that typically strawberry vagina appearance was present. Whiff test may be positive or may be negative. Clue cells will always be negative. What is whiff test? What I am talking about. Whiff test is when to the discharge you add 10% potassium hydroxide, you get a fishy odor. And whiff test is positive always in bacterial vaginosis. It can be positive or negative in trichomonas. The other thing which you have to remember is in bacterial vaginosis, pruritus is absent. But sometimes in bacterial vaginosis, there is secondary infection which is present, and this secondary infection may lead to itching. Right? तो नीट में एक बार ये क्वेश्चन आया था last time, I think this year only, 2021 NEET. They had asked that there is a female in whom whiff test was positive, clue cells were present, and it was a dirty grey discharge, dirty white discharge, pruritus was present. अब options में trichomonas was also given and bacterial vaginosis was also given. So please remember that pruritus is not seen in bacterial vaginosis, but sometimes you may get it due to secondary infections, right? And if this question can be asked in NEET, it can be asked in your exams as well. Then, when you will do a wet mount in trichomonas, you are going to get motility. You will see something is moving, right? And it is an STD. Trichomonas is sexually transmitted, so partner treatment should always be done. As far as candidiasis is concerned, patient की complaint कभी भी discharge नहीं होती candidiasis में. Patient की main complaint is itching, pruritus. Discharge is scanty. Right, हमेशा candidiasis का discharge will be scanty and it is cottage cheese like discharge. फटे हुए दूध जैसा, cottage cheese like discharge, and it is never foul smelling. If you get words like splash dysuria, then they are talking about candidiasis. pH of the discharge is very important. It is less than 4.5. So candidiasis is the only organism which can survive in acidic media. Whiff test will always be absent. And on wet mount, you are going to get hyphae or pseudo hyphae. Right? Now, treatment of bacterial vaginosis, trichomonas and candidiasis. Now, please remember that in non-pregnant females, treatment of bacterial vaginosis is metronidazole. In pregnancy also it is metronidazole, or you can use clindamycin, right? For trichomonas in non-pregnant female also it is metronidazole, and pregnancy also it is metronidazole. As far as candidiasis is concerned, for a pregnant female, treatment is fluconazole. And in candidiasis in a pregnant female, we do not use oral fluconazole. We use topical imidazoles. That is, we will use clotrimazole cream or we will use miconazole cream. Partner treatment is needed only in trichomonas. Right? Now, please remember that there is a syndromic management of vaginal discharge as has been advised by NACO. तो हमारी जो national guidelines है वो ये कहती हैं कि अगर patient vaginal discharge के साथ आ रहा है तो we have to give them a kit. That kit is kit number 2, which is green in color, very important. And is kit number 2 में there are 2 drugs. Tablet fluconazole 150 mg single tablet and tablet secnidazole 2 grams single tablet. Instead of metronidazole in the kit, there is secnidazole. Please don't ask me why. I don't know. This is government policy. They are giving secnidazole 2 grams, but the treatment of choice was metronidazole. Right? And when you are doing syndromic management, you cannot see this word not, so I'm writing it here. So when you are doing syndromic management of vaginal discharge, partner treatment is not given, right? You don't have to give any partner treatment when you are doing syndromic management. That's very important. Now, everything about kits, these kits, they are very important. Their number, their composition and their color. And Dr. Mukh Mohit has told you them in detail in OBGY PSM integrated sessions. But if you feel that integrated sessions are not meant for you, it is meant for students applying for NEET PG, then you are very sadly mistaken. I want all of you to go on Marrow's live YouTube channel and watch all the integrated sessions, especially in OBGY. I can tell you it is going to clear your many concepts. Whether it is OBGY PSM, that's very important. Whether it is OBGY pharmacology or whether it is OBGY and pathology. They are very important integrated sessions. Right? Once this session is over, this is going to stay here. I want you to copy this chart. This is the infection and CDC recommendation of the dosage of the drug in a non-pregnant female. I'm not reading it out because already we are running out of time. So this you can copy once the session is over. Coming to question number 22. A young girl who has not attained menarche complains of cyclical pain in abdomen. On examination, her breast development was normal and local examination of the external genitalia showed the following image. The probable diagnosis is. So what you are seeing over here, you are seeing a tensed hymen. right, and a bulging hymen, and this hymen doesn't have any opening. So this is a case of imperforate hymen, right? Now, whenever a patient comes to you with complaint of cyclical pain in abdomen, there is no menarche, and on examination you are getting bulging tensed hymen, the diagnosis becomes imperforate hymen. Now, please remember, a similar complaint you are going to get in transverse vaginal septum also. But in transverse vaginal septum, there will be no bulging hymen, right? And if you ask the person to cough, cough impulse will not be present. Whereas in imperforate hymen, जब patient cough करेगा तो hymen is a thin membrane, तो जब patient cough करेगा तो cough impulse will be felt on the hymen. Whereas in transverse vaginal septum, bulging hymen नहीं होगा and cough impulse will be absent. Both these are varieties of cryptomenorrhea. What is cryptomenorrhea? Hidden menstruation. So this is hidden menstruation. Over here, everything is normal in the female. A female menstruates normally, but the menstrual blood fails to come out, right? So menstrual blood is not coming out. That is what is your cryptomenorrhea. And this blood, it is going to accumulate in vagina, and when it accumulates in vagina, it is called as hematocolpos. It can accumulate in uterus, hematometra. It can accumulate in the tubes, hematosalpinx. Right? Now, and because of the big bulging uterus, when you are going to do a per abdominal examination or a per abdominal examination में या a per rectal examination, please remember these females are virgin females, so I am not going to do a per vaginal examination. अगर मुझे uterus के size को assess करना है, I will do a per rectal examination or a per abdominal examination, never a per vaginal examination. And I am going to see that the uterus is big and bulging. And because uterus is big and bulging, it can press the urethra. So patient may come to you with urinary retention, or patient may come to you with constipation if it presses the bowel. Then a long-term complication could be retrograde menstruation, right? And retrograde menstruation can lead to endometriosis. So a long-term complication of transverse vaginal septa or imperforate hymen is endometriosis. Management of imperforate hymen is you give a cross-shaped incision on the hymen, and this is called as a cruciate incision, and all the collected blood will come out, right? Investigation of choice to diagnose to diagnose imperforate hymen or to differentiate it from transverse vaginal septum is ultrasound. But the gold standard investigation to differentiate between imperforate hymen and transverse vaginal septa is MRI. So these are all the possible questions which they can ask you on imperforate hymen and transverse vaginal septum. Coming to question number 23. In question number 23, a patient is taking treatment for infertility and was given injection HCG for ovulation trigger. The ultrasound of the pelvis shows some ascites and ovarian image is given below. The probable diagnosis is. Now, what are you seeing over here? In this, you are seeing there are big follicles, big cystic areas. बहुत बड़े follicles and too many follicles, right? So if you are getting big follicles which are more than 1 centimeter in size and they are more than 20 in number, and the patient was on IVF, then that means it is a case of ovarian hyperstimulation syndrome. Now, one very important mistake which you do is you say ki ma'am, because this is ovarian hyperstimulation syndrome because the follicles are not arranged around the periphery. PCOS में follicles are arranged around the periphery, necklace pattern, and that is why it is PCOS. यहाँ पे follicles are not arranged around the periphery, that is why it is OHSS. Please remember that PCOS में, yes, you do get follicles arranged around the periphery, but then that is not a diagnostic criteria. That is not a diagnostic criteria for PCOS. The diagnostic criteria, the ultrasound diagnostic criteria for PCOS is if you are getting more than 12 follicles in size, right, which are between 2 to 9 millimeters, sorry, more than 2 follicles in number, which are more than 2 to 9 millimeters in size, which are between 2 to 9 millimeters, more than 12 follicles. That is a diagnostic criteria, or if the volume of the ovary is more than 10 cc. Necklace pattern is not a diagnostic criteria. अगर आपको 12 follicles मिल रहे हैं which are 2 to 9 millimeters in size, right? So, and they are in the center of the ovary, then also it is PCOS. राइट सो जस्ट बिकॉज यहाँ पे सेंटर में है इसीलिए ये पीसीओ ये OHSS नहीं है. ऐसे में भी this is PCOS, this is OHSS because over here the size of the follicles is more than 1 centimeter. In PCOS the size of the follicle is less than 1 centimeter. It is between 2 to 9 millimeters. Is this point clear to all of you? And these findings, they should be present in one or both the ovaries. So this is the ultrasound criteria for diagnosing PCOS. Clear to all of you? Now, what is OHSS? OHSS में जो size होता है follicles का, that becomes more than 1 centimeter and they are more than 20 in number. तो जब हम IVF के patients में, you will give them HMG. HMG is LH plus FSH, right? HMG जब हम देते हैं, this HMG leads to big follicles. You are giving LHFSH जिसकी वजह से there will be big follicles. अब big follicles का होना is not OHSS, right? OHSS तब तक नहीं होगा जब तक का ये follicles rupture नहीं करेंगे. तो अगर मुझे big follicles दिख रहे हैं, I am not going to be scared कि मेरे patient को OHSS हो गया. I should be scared if this big follicles get ruptured, right? So OHSS doesn't mean presence of these large follicles. It means that these follicles, large follicles, are ruptured. And जब भी आप follicles का rupture कराते हो, whether you use clomiphene, whether you use HMG, the drug which you give for rupture of follicles, that is ovulation trigger. It is HCG. So now let me tell you again. Let me, make it simpler for you. जब हम IVF करते हैं, तो हम IVF के लिए I can use either clomiphene or I can use HMG. Better drug is HMG, which is LH and FSH. I will give HMG to the patient so that उसके ज़्यादा follicles बने. There are more follicles which are formed. Now, if more follicles are formed and they are big in size, then I shouldn't get afraid that OHSS has happened, right? Because presence of these follicles doesn't simply mean OHSS. Problem is going to happen when these follicles will rupture. And for the rupture of follicles, everything is in my control. Because for rupture of follicles, the drug which you have to give is injection HCG. So as a gynecologist, if I see big follicles which are more than 1 centimeter in size, which are more than 20 in number, I shouldn't give HCG. So the triggering factor, trigger for OHSS is injection HCG. When you give injection HCG, the follicles are ruptured. अब rupture हो गए तो problem क्या होगी? When these big follicles are ruptured, they are going to release inflammatory markers. And one of the very important inflammatory markers which they release is VEGF, vascular endothelial growth factor. Now, what this VEGF does is, it makes the capillary wall leaky. So, it will make the walls of the capillaries leaky. So, imagine एक pipe है जिसमें छोटे-छोटे holes have been made, and through this pipe water and sand was passing out. Now, if through this pipe water and sand was moving and you've made tiny little holes, water is going to come out, sand is going to remain inside. Same thing happens over here. This VEGF makes the capillary walls leaky. because of which the plasma comes out and it collects in third space. That means there will be ascites, there will be pleural effusion, there will be pericardial effusion. And the blood cells will remain inside. Now, because blood cells remain inside, there will be hemoconcentration. And this hemoconcentration can lead to multiple organ failure. Right? अब ये पूरा OHSS का control is in my hand. If I am suspecting that patient may land up into OHSS, what I have to do? I don't have to give this. So the moment I see कि इतने बड़े बड़े follicles हैं in the ovary, my step should be do not give injection HCG or delay giving injection HCG. Till the time I do not give injection HCG, my patient is not going to have anything. Clear to all of you? Yes. So over here, your question was injection HCG was given, right? Ascites was there and big follicles. All these three together make up OHSS as the diagnosis. I hope this is clear to all of you. So, bachcho, please, superficial knowledge is never going to help you. I want your concepts to be strong. If your concepts are strong, you can answer any question related, and no matter how the question is twisted, you will be able to answer it. So please do not mug up the answers. Do not ratify the USG images. Try to understand the concept behind them, right? Question number 24. Which of the following is an absolute contraindication of IUCD? And as I told you, there is a very, very good integrated session of OBGY and PSM where all your doubts related to contraception will be cleared. I want all of you to watch that session on YouTube on Marrow Live, right? And in that session, we have discussed this question about absolute contraindications for IUCD. Please remember that there are only 4 absolute contraindications. This is a slide from that session only. Number 1, undiagnosed vaginal bleeding. Number 2, distorted uterine cavity. Now, undiagnosed vaginal bleeding, distorted uterine cavity can be seen in case of cancer cervix, cancer endometrium, uterine anomalies or fibroid. Right? Then active pelvic infection. If patient has presently PID, then that's a contraindication. Previous history of PID is not a contraindication. Then suspected pregnancy. These are 4 absolute contraindications for IUCD, whether it is copper IUCD, whether it is progesterone containing IUCD Mirena. Now there is one contraindication which is specific for copper IUCD, and that is Wilson's disease, and one which is specific for Mirena, that is history of breast cancer. These 4 are for both copper and Mirena. For both copper IUCD and for Mirena. Now, here I have specifically told you that previous history of ectopic pregnancy is not a contraindication for IUCD. Past history of PID is not a contraindication for IUCD. IUCDs can be used in nulli gravida females. IUCDs should be dispersed in red bag. Females' hemoglobin should be more than equal to 7 gram% for IUCD insertion, and risk of infection with IUCD is increased typically within 20 days of inserting IUCD, right? So risk of infection is increased when you are inserting IUCD, and the risk is more with copper IUCD than with Mirena, because Mirena has progesterone, and progesterone will make cervical mucus thick so that there will be decreased risk of PID. The most common PID which is associated with IUCDs is actinomyces. Now, one relative contraindication for copper IUCD is menorrhagia or dysmenorrhea, because when you insert copper IUCD, patient experiences more bleeding. So if patient has menorrhagia, I am not going to prefer copper IUCD. Rather, agar patient ko menorrhagia hai, तो Mirena is the preferred contraception. Why? Because Mirena has progesterone. And all of you know कि bleeding का क्या मतलब है? Bleeding का मतलब है shedding of endometrium. And जैसे ही हम progesterone देंगे, progesterone will support the endometrium, shedding will stop, so bleeding will become less. So if your question says patient has menorrhagia, I am not going to prefer copper IUCD. Rather, I am going to prefer Mirena over copper IUCD. Clear to all of you? Yes? Next question. false statement regarding non-scalpel vasectomy. Now, in this question, even if you didn't know about other three options, you always know that a non-scalpel vasectomy, or even after normal vasectomy, after a surgical vasectomy, sterility is not going to happen immediately. We always tell you that you have to tell the male partner to use a contraceptive for at least add-on contraceptive for at least 3 months, right? So this means कि option B गलत है. अब I don't know option A, C and D क्या है. You don't know the details, but you know that option B is definitely wrong. So even if you don't know the details of non-scalpel vasectomy, still you can answer this question, right? Now let us talk a little bit quickly about details of non-scalpel vasectomy, because that question has been asked. So non-scalpel vasectomy is done with the help of two instruments. One is a dissecting forceps and another is a ring clamp, right? Ring clamp and a dissecting forceps. These are the two instruments, A and B. A is a ringed clamp, which is used for non-scalpel vasectomy, and B is a dissecting forceps. Why it is called as non-scalpel vasectomy? Because I am not going to give any incision. Now, why am I calling instrument B as a dissecting forceps and not a scissor? So please compare image B with image C. Image B mein you can see a lock, and I was telling you all forceps have a lock. Scissors don't have lock. So image C is a Metz bomb scissors. And image B is a dissecting forceps, and A and B are the instruments which are used for non-scalpel vasectomy, right? Ab non-scalpel vasectomy mein what are you going to do? In non-scalpel vasectomy, you are going to give local anesthesia, right, to the male partner, and after giving local anesthesia, you are going to hold the vas deferens, right? Stabilize the vas deferens with the help of the ringed clamp. Right, after stabilizing the vas deferens with ring clamp, you are not going to give any incision. With this dissecting forceps, you are just going to puncture the skin, and from the punctured skin, you are going to take out vas deferens and you are going to ligate and cut it. Right, so I am not giving any incision. This is a day care OPD procedure. This is non-scalpel vasectomy. Right, now non-scalpel vasectomy, it is done under local anesthesia. It is an OPD procedure. When you do a non-scalpel vasectomy, men are going to develop sperm antibodies following vasectomy. Now, rare complications of NSV are hematoma formation and infection. And for this, the treatment is scrotal support, heat and antibiotics. But what is never seen, chahe antibodies ban rahi hain, but you will never see immune related diseases. You will never see an increased chances of cardiovascular disease. Pehle people used to say कि अगर vasectomy करा लोगे तो chances of prostate cancer are increased. Nothing of that sort is seen. Then it is not this कि अगर आपने vasectomy करा ली तो there will be adverse sexual pleasures or adverse sexual effects. There won't be any decreased volume of the ejaculate, nothing. Right? All these are not seen when you do a vasectomy. Right? Now, vasectomy, one thing which you have to remember is, vasectomy is a permanent method of contraception. You are never going to say it is a temporary method of contraception, and the failure rate of vasectomy is 0.1%. But in rare circumstances, a male may come to you for reversal. But that doesn't mean कि हम vasectomy को कह देंगे it is a temporary method of contraception. No. Vasectomy and tubectomies are permanent method of contraception. You people so many times get confused कि ma'am reversal तो हो सकता है ना. So that reversal is done rarely. Right? But by and large, it is a permanent method of contraception. Now, अगर vasectomy reversal करोगे, right, if a male says that I want to get a vasectomy reversal, then it is associated with a pregnancy rate of 70 to 80% and a fertility rate of 90%. 90% males में उनकी fertility वापस आ जाएगी, which will lead to a pregnancy rate of 70 to 80%. But as the time is going to, the main thing is कि जितना ज़्यादा time हो जाएगा after vasectomy, उतने कम chances होंगे reversal के successful होने के. Right? So for reversal to be successful, the reversal should be done within 3 years of performing vasectomy. Number one. Right? So number 1 point, vasectomy is permanent method, not temporary method. You may do a reversal, and reversal should be done within 3 years of performing vasectomy. Number 3. Suppose there is an HIV patient जिसने vasectomy करा ली, and they ask you कि ma'am, should we use a condom? Now, हमने तो vasectomy करा ली, तो अब तो HIV का transmission नहीं होगा. So please tell them that vasectomy कराने से contraception नहीं, it is a method of contraception. It is not a method of prevention of HIV. HIV का transmission still is going to happen because semen will still be present, right? So if you are doing a vasectomy in an HIV positive female, in a HIV positive male, that is just going to prevent conception. It is not going to prevent HIV transmission. I hope have I made my point clear to all of you? Yes. Now, sterility. Sterility is never immediate after vasectomy. Sterility happens after 3 months or after 20 ejaculates. So, after 3 months or after 20 ejaculates, you have to do ideally 2 semen analysis. And in both the semen analysis, when you get a zoospermia, then you have to tell the male partner to stop using any additional method of contraception. But then, अगर वो HIV positive है, तो हम उनको ये नहीं कहेंगे कि वो barrier method ना use करें. उनको तो barrier method lifelong use करना है to prevent HIV transmission. Clear to all of you? Yes? Okay. Question number 26. A lady with infertility undergoes laparoscopy for assessment of her fallopian tube. Chromopertubation was done and a dye was passed through a cannula into her tubes. The dye used for performing chromopertubation is... Right. So all of you know that the investigation of choice, if I ask you what is the investigation of choice for tubal patency, the investigation of choice for tubal patency is HSG, hysterosalpingography. Now, best time for doing hysterosalpingography is between day 7 to day 10. Contraindication for doing HSG is if there is active PID, active genital TB, or if there is a suspected pregnancy. Now, in HSG, the instrument with which you are going to use is a Leach-Wilkinson cannula. Leach-Wilkinson cannula. And through this Leach-Wilkinson cannula, I am going to pass a radio-opaque dye, and after that I am going to do serial X-rays to see whether the dye comes out or not. Right? अब कई बार क्या होता है that when you are doing HSG, due to pain, there is spasm of the cornual end of the tube, जिसकी वजह से हमें bilateral cornual block मिलने लगता है on HSG. राइट ये ब्लॉक किसी रीजन और कोई पैथोलॉजी नहीं है ब्लॉक की. ब्लॉक का मोस्ट कॉमन रीजन इज दैट द कॉर्नुअल एंड ऑफ द ट्यूब्स गो इनटू स्पैज्म. सो इफ दे आस्क यू व्हाट इज द मोस्ट कॉमन कॉज ऑफ बायलेटरल कॉर्नुअल ब्लॉक ऑन HSG, योर आंसर विल बी फिजियोलॉजिकल स्पैज्म. राइट? तो जब भी हमें ट्यूब्स ब्लॉक्ड मिलती हैं तो हमारा नेक्स्ट स्टेप क्या होता है? जब भी आपको ट्यूब्स ब्लॉक मिलेंगी, हमारा नेक्स्ट स्टेप होता है गोल्ड स्टैंडर्ड टेस्ट फॉर ट्यूबल पेटेंसी. एंड व्हाट इज द गोल्ड स्टैंडर्ड टेस्ट फॉर ट्यूबल पेटेंसी? दैट इज लैप्रोस्कोपिक क्रोमोपर्ट्यूबेशन. Laparoscopic chromoperturbation. Laparoscopic chromoperturbation में हम एक laparoscope, we are going to insert it in the abdomen and we are going to pass a dye. And which dye are we going to pass? Gentian violet dye. Right? Sorry. Methylene blue dye. I was just reading that option and sorry. Methylene blue dye. You will pass methylene blue dye and then with the help of laparoscope, you are going to see whether the dye is coming out or not. This is what is laparoscopic chromoperturbation. So whenever you get a bilateral tubal blockage on HSG, the next step is laparoscopic chromoperturbation. Now, laparoscopic chromoperturbation के साथ में क्या करेंगे? Because I know that most of the times the block is happening due to spasm. So under hysteroscopic guidance, I will pass a thin wire and I will try to relieve that spasm. And that is what is called as hysteroscopic cannulation. Right? So sometimes they ask you that if you get both the tubes blocked, what is the next step? The next step becomes laparoscopic chromoperturbation plus hysteroscopic cannulation. अब कई बार इतना बड़ा option is not given in the answer. So what they are going to write is laparoscopy plus hysteroscopy. Simple. So please remember, if you are getting bilateral tubal block on HSG, the next step is laparoscopy plus hysteroscopy. Right? Now, अगर block relieve नहीं हुआ by laparoscopy and hysteroscopy, that means it's a pathological block, and most common cause of pathological bilateral cornual block on HSG is genital TB. Right? Now, if they ask you what is the best management for blocked tubes, best management for blocked tubes is IVF. Now, in which conditions in gyne, definitely you have to do a laparoscopy. So, you definitely have to do a laparoscopy if it is unresolved PID, if the patient has chronic pelvic pain, and if patient has endometriosis. एंडोमेट्रियोसिस ऑप्शंस में लिखा होगा या सेकेंडरी डिस्मेनोरिया या चॉकलेट सिस्ट. So in these conditions, definitely you have to do laparoscopy. Clear to all of you? Yes? Question number 27. Meagh syndrome is. Now, again over here, I have been telling you that in the lectures constantly that there is a change in Meagh syndrome and pseudo-Meagh syndrome. Meagh syndrome is now due to 4 ovarian tumors. If there is a fibroma, a thecoma, Brenner's tumor, or a granulosa cell tumor of the ovary, right? Plus there is right-sided pleural effusion and ascites. This is what is Meagh syndrome. Pseudo-Meagh is any other ovarian tumor plus right-sided pleural effusion and ascites. पहले कहते थे कि फाइब्रोमा के साथ अगर मिल रहा है राइट साइडेड प्लूरल एफ्यूजन एंड असाइटिस दैट इज मीग, एंड अगर थिकोमा, ब्रेनर्स ट्यूमर एंड ग्रैनुलोसा सेल ट्यूमर के साथ मिल रहा है दैट इज स्यूडोमीग. नाउ द डेफिनेशंस हैव चेंज्ड. ऑल दीज 4 कम अंडर मीग सिंड्रोम. नाउ अदर इंपॉर्टेंट पॉइंट इज fibroma is a solid tumor, it is a benign tumor, and it is a stromal tumor. It is not a sex cord tumor. It comes in sex cord stromal tumors, but it is a stromal tumor, right? So this is what a fibroma is. Brenner's tumor is again a solid tumor, a benign tumor, and it is an epithelial cell tumor. Granulosa cell tumor is a malignant tumor, and it is a sex cord tumor. Thecoma is also a malignant tumor, and it is a stromal tumor, right? So benign fibroma plus ascites plus hydrothorax is Meagh syndrome. It is not malignant. There is nothing like malignant fibroma. Fibromas are always benign. Brenner's tumors are always benign, right? Next question which they may ask you is pseudomyxoma peritoni. Pseudomyxoma peritoni. Pseudomyxoma peritoni, there can be 2 questions. Most common ovarian tumor associated with pseudomyxoma peritoni. Then that is mucinous adenocarcinoma. Mucinous cyst adenocarcinoma. Cyst adenocarcinoma. Right? But if they ask you overall most common tumor associated with it, they are not saying ovary. Then it is appendix tumor, right? So pseudomyxoma peritoni is a condition in which the peritoneum is filled with gelatinous material, and that is a very bad prognosis because it is a recurrent condition. Question number 28, Bartholin cyst is located on. Now, that is again a very easy question, that Bartholin cyst is located on the vestibule. Now, in the vestibule, what is vestibule first? So, vestibule is that area which is bounded by clitoris anteriorly. Laterally, it is bounded by labia minora, and posteriorly, जहाँ labia minora meet करता है, that is called as fourchette. So, vestibule is that area which is bounded by clitoris, labia minora and fourchette, right? Posteriorly where labia minora meet, that is fourchette. Posteriorly where labia majora meet, that is posterior commissure. Now, this vestibule, it has got 6 openings. Number 1, this is urethra opening. 2 and 3. These are openings of skin glands, right? And these are also called as paraurethral glands. Number 4 is opening of the vaginal introitus. And 5 and 6 are the openings of Bartholin glands. Bartholin glands are the greater vestibular glands. They are homologous to Cowper's gland or bulbourethral gland. Please do not say that Bartholin gland is homologous to prostate gland. Which gland is homologous to prostate gland? Spleen gland is homologous to prostate gland. Right? Now, where is the gland located? As you can see, the gland is located between labia majora and minora, and its duct is going to open in the vestibule at the junction of anterior 2/3 and posterior 1/3. That is either at 4 o'clock and 8 o'clock position or 5 o'clock and 7 o'clock position. So, if you are getting a cyst in the posterolateral wall of vagina, if you are getting a cyst in a posterolateral wall of vagina, it has to be Bartholin cyst. If you are getting cyst in anterolateral wall of vagina, then that is Gartner's cyst. Now, if someone asks you what is the most common cyst of vagina, most common vaginal cyst, please do not say Bartholin cyst. Most common cyst जो होती हैं, they are inclusion cysts. Now, Bartholin cyst का management has undergone tremendous change. पहले हम, we used to just tell you that if they say what is the management of Bartholin cyst, you have to say marsupialization. But now it is not so. And that is why I want all of you who are listening to me and have not yet subscribed to my Instagram handle, Dr. Sakshi Arora Hans Obs and Gyne, please subscribe to it, because all the updates which I want you to know, I keep on posting there, and there I posted to you the management of Bartholin cyst. See, जब भी cyst होगी and abscess होगी, उसमें difference क्या होगा? Cyst will be painless, whereas abscess will be painful, right? But then whether it is a cyst or whether it is Bartholin abscess, management now is incision and drainage, right? Earlier we used to say Bartholin cyst ka management is marsupialization. Now we say it is incision and drainage. Please remember, if your question is saying that Bartholin cyst is happening in a female who's more than 40 years, or they say postmenopausal female, if they say that on, touching you can feel some solid mass in the cyst, or if the cyst is fixed to some structure, then it you should get the suspicion of Bartholin cancer, and in that case your next step becomes biopsy. In that case you are not going to say that I am going to do incision and drainage. If the cyst is happening in a female more than 40 years or postmenopausal female, or if the cyst is solid, or if it is attached to nearby structures, your next step in management is biopsy. But if it is a cyst which is asymptomatic and it is less than 3 centimeters, no treatment. If it is more than 3 centimeters, incision and drainage. If it is a symptomatic cyst, a symptomatic cyst or abscess में differentiate करना, it's a little difficult. The only thing is that abscess will be red and hot and cyst will not be that. But whether it is abscess or whether it is symptomatic Bartholin cyst hardly matters, because management is incision and drainage. जब आप incision and drainage करोगे, simultaneously you are going to insert a small catheter which is called as a word catheter. Now, suppose if incision and drainage करने के बाद the cyst recurs, so you can do incision and drainage up till 2 times. Now, if recurrence is happening for 3rd time or more than 3 times, Then the management is marsupialization. So this is an update which I want to give you on management of Bartholin cyst. So these days, if simple question comes, management of Bartholin cyst, your answer will be incision and drainage and not marsupialization. Clear to all of you? Then the next question was identify the instrument. This instrument is very easy to identify. What you are seeing over here, you are seeing that it has a blunt end and it has a sharp end. This is a sharp and blunt curette, right? So as I told you that there is this video on instruments and obs and gyne on Marrow YouTube live channel. I want all of you to watch that video. A second version of this question was, some students are saying that this instrument was shown and they had asked that the least likely used for which, this instrument is least likely used for which of the following. So basically this instrument is a uterine sound. This instrument is a uterine sound. In a uterine sound, you are going to get a smooth curve. Can you see a smooth curve over here? This, it is smoothly curved and its proximal end will be olive tipped and it will have calibrated markings present. So if you have a smoothly curved thin instrument which has calibrations and an olive tip, that's a uterine sound. Now, in the same video, I have told you what are the uses of uterine sound. So, uterine sound will help you in knowing the direction of the uterus, whether it is retroverted or whether it is anteverted, and the size of the uterus. So, before you do suction evacuation, before you do dilatation and curettage, before you insert an IUCD, you should know about the direction and the size of the uterus. Then, because it is so thin, it can be used as the first dilator of the os. Then it can help you in knowing the uterocervical length, and again in NEET they had asked you what is the normal uterocervical length. Normal uterocervical length is 6 to 8 centimeters. Then it can help you in identifying uterine anomalies like uterine septum, and it can also help you in confirming the position of misplaced IUCD. Right? So these are the uses of uterine sound. So dilatation and curettage, yes. For removing IUCD, yes. For suction evacuation, yes. For endometrial biopsy, we are going to use endometrial biopsy curette, right? And for endometrial aspiration biopsy, we use Carman's cannula in India, and abroad they use Vabra aspirator or a Pipel. Right? So for endometrial biopsy, you use an endometrial biopsy curette. For endometrial aspiration biopsy in India, we use a Carman's cannula and Vabra aspirator or a Pipel. Clear? Okay. Question number 13, a straightforward question. Epithelial lining of fallopian tube is. So all of you know it is ciliated columnar epithelium, and it is too much time now. A lot of time we have discussed it. So I am just showing you this table where I have written down the lining of the various organs, female genital tract, and I want you to copy which organ has which lining. Right? So I think this is clear to you. You can copy this. I have nothing to explain over here. Now, there are two questions which they may ask you based on named structures. PEG cells are seen in, or interstitial cells of Kagel are seen in. Both these named cells are seen in fallopian tube. Right? Interstitial cells of Kagel are the pacemaker cells which help to initiate fallopian tube contraction. PEG cells, we don't know the function. Right? So, PEG cells and interstitial cells of Kagel, they are seen in fallopian tube. Clear? Okay. Coming to the second last question, identify the arrow marked area in this image. So, in this image, if you zoom it, you are going to see a follicle which has a small cavity. The moment a cavity is seen, that means it's an antral cavity, and that means it's an antral follicle. Right? Now, how are you going to differentiate between various follicles, and what are these follicles? See, oogenesis, all of you know, it begins in intrauterine life. And in oogenesis, what happens is that the oogonia will undergo mitosis and they will change into primary oocyte. Right? This is going to happen in intrauterine life. Now, primary oocyte is going to undergo meiosis 1, but then this division is going to get arrested in prophase. And in which stage of prophase? In diplotin stage of prophase. And the arrested state is called as the dictyate state. Now, in intrauterine life, nothing more is going to happen. The arrest is going to happen, and this primary oocyte in dictyate state is going to remain like this till puberty, right? At puberty, this meiosis 1 is going to get complete and a secondary oocyte will come out, and this is what is called as ovulation, right? So in intrauterine life, जब primary oocyte is arrested state में होता है, in dictyate state, it gets surrounded by a single layer of flat cells, and that is called as granulosa cells, and this is a primordial follicle. So when this primary oocyte in dictyate state is surrounded by single layer of flat cells, that is a primordial follicle. Now it is going to grow a little, and this flat cell is going to convert into cuboidal cells, and it will be called as primary follicles. Still, it will be a single layer. Now what is going to happen? This cuboidal granulosa cells are going to multiply, and this primary oocyte will be surrounded by this black layer which is called as zona pellucida, and apart from this multiple granulosa cell layer, which is I have shown in green color, you will get a few theca cells also. So if you are getting a primary oocyte which is surrounded by zona pellucida, multiple layers of granulosa cell and a few theca cells, that is what is a secondary follicle or a pre-antral follicle. The moment a cavity appears, antral cavity, that is called as antral follicle, and in antral follicle you will get proper theca cells, theca interna and theca externa. This is what is a tertiary follicle or an antral follicle, and this antral follicle, when it reaches 18 to 20 millimeters in size, this is called as Graafian follicle, and this is the size of the follicle which is going to be present immediately before ovulation. So at puberty, जब ovulation होने वाला होगा, right, at that time you are going to get a Graafian follicle, which is actually an antral follicle, but a large antral follicle which is 18 to 20 millimeters in size, right? If they ask you when are the follicles maximum seen, maximum number of follicles, they are seen in the 5th month of intrauterine life, that is 20 weeks. At that time the number is 6 to 7 million. Then at the time of birth they are 1 to 2 million, right? And by the time a female reaches puberty, they are 4 to 5 lakh. Clear? Okay. So in this question, because you were seeing a cavity, a small cavity can be seen, so it is an antral follicle or a tertiary follicle. Last question, which of the following is not true about colostrum? And I have just told you to remember the mnemonic KFC. Always in my classes and in marrow videos, I tell you to remember KFC, and I tell you that colostrum is a yellow colored fluid which is rich in immunoglobulins. It has got everything more than breast milk. There are only 3 things in colostrum which are less than breast milk. And these things are KFC, where K stands for potassium, F for fat, and C for carbohydrate, that is sugar, right? So it has high amount of fat and sugar, that's wrong, right? It has got low amount of fat and sugar. This is what is less in colostrum than breast milk, KFC, right? So that's all what you have to remember about colostrum. And I hope you got a lot of information about this session. This session was informative for you, and you are going to make the most use of this session. Now, tomorrow or day after tomorrow, I am going to give you a study planner, that how you are going to plan your study so that you can clear your exams or your June 2022 FMGE exam. So stay tuned, and yes, about the important topics. Now, since it is already 8 o'clock, I believe, so we should end the session over here. I am going to give you a list of important topics, and yes, someone has asked me to tell you how to use marrow for clearing FMG exam. I'm going to talk about my subject. That video also I'll upload. So thank you for being patient, and thank you for being here with me during this entire session, which became a little lengthier than what I had thought. And all the best to all of you. Keep studying and keep clearing your concepts. I have started a 7-week challenge for NEET PG students, where every day on Instagram I'm telling them a topic which they have to revise. Same challenge even you can take. So every day you have to revise one topic of OBGY, and you have to do questions related to that topic. And then every Monday starting from 24th Jan, I will do a session for NEET PG where I will be talking about basic MCQs which are important for NEET PG, and they will also be important for FMGE. So today the challenge has started, 7-week challenge for completing OBGY, and today's topic was abortion. If you have not started that challenge, I want all of you to start the challenge. So by doing that challenge, your entire OBGY will be completed by 6th of March. Right, and probably we will be holding webinars for FMGE on Marrow as well. So whenever we are holding webinars for FMGE or for Obs and Gyne, I'll keep you informed. In the meanwhile, thank you, take care and keep safe. Bye.